have taken efforts to join us in this beautiful evening from all over India. Once again, welcoming you all to the academic webinar organized by Women in Nephrology, WIN India. I am the host of today's program. Myself, Dr. Jyoti Priya. I'm working as consultant nephrologist in MGM Medical Center in Kerala. We all know during the progression of CKD, the requirements and utilization of different nutrients change significantly. And these changes ultimately place the patients with kidney disease at higher risk of nutritional and metabolic abnormalities. So, understanding the applicable nutritional principles, the available methods for assessing the nutritional status, establishing patient-specific dietary needs, and preventing or treating potential or ongoing nutritional deficiencies and derangement, therefore essential for optimal care of chronic kidney disease patients. And we also know that diet potentially plays a major role in the progression and complications of CKD, especially in pre-dialysis CKD, and dietary strategies for reducing the progression of kidney disease has a significant role in the management of chronic kidney disease. Today, our academic webinar will be focusing on the nutrition in pre-dialysis chronic kidney disease patients. Before proceeding to our academic talks, let's take this opportunity to pay our warm tribute to late Professor Anita Saxena, who was the Professor of Nephrology and Renal Nutrition at the prestigious Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and who had made a remarkable contribution in the field of renal medicine and whose contribution in this field cannot be undermined. For paying this tribute, I invite Dr. Amit Gupta, who is the former professor and head of nephrology SGPGI and who is currently the director and head Department of Nephrology and Renal Transplantation, Apollo Medic Super Specialty Hospital, Lucknow. I also invite Dr. Urmila Anand, the president of Women in Nephrology India, WIN India, professor and head Department of Nephrology, Amrita Hospitals, Faridabad. I now request Dr. Manjusha Yadla, secretary of WIN India, professor, head of nephrology, Gandhi Medical College, Hyderabad, to take over the session. Over to you, ma'am.
Thank you, Dr. Jyoti Priya. Vipul, can you just start sharing the screen? Before going to the session as such, which is focusing on nutrition in pre-dialysis CKD, which is in fact the second in series of sessions on nutrition. We are going to come more with the sessions with respect to the nutrition, but especially today, once we are focusing on this nutrition aspect of it, we are here to pay our warm tributes to Professor Anita Saxena, as has been said. Madam was very well associated with us, the Women in Nephrology India. She was one of the key members of establishment and, of course, the spread of the wings of Women in Nephrology India. She was the executive member. She had contributed immensely for the growth of the Women in Nephrology India, starting with its association, starting with the inception, starting with the thoughts, and of course, driving us towards the journal establishment, etc., etc. Her contributions are wordless and immense. What I can say, they were very potential. But unfortunately, Madam, we lost Madam on 4th November 2022, exactly about a year back when she was visiting US. So on this occasion, I would just take a few minutes more to say a few words about Dr. Anita Saxena. Then I request Dr. Amit Gupta to take over regarding the pay of the tributes. Next slide, Bipul. Professor Anita Saxena, as has been said, she is professor in Department of Nephrology in SGPGI, Lucknow. She has completed her postdoctoral fellowship during 1995-1996, and this was in Addenbrooke's Hospital. She was member of various professional organizations. In fact, she was key member for establishment of Society of Renal Nutrition Metabolism. She conducted innumerable workshops in renal nutrition since 2014 and also established the Journal of Renal Nutrition Metabolism, which is a very customer-friendly journal which accepts the articles very easily with a thorough review and a faster review. She, of course, has good number of publications to her credit, and she's also written handbook on renal nutrition. And of course, if I go on like this, there are many things which can be said about her. Madam has been in our hearts. Madam, her association with us is phenomenal. On this occasion, I think we all should be paying a warm tribute to Professor Anita Saxena and her accomplishments, achievements, and contributions towards renal nutrition and renal medicine. Thank you so much for the opportunity. And now may I request Dr. Amit Gupta sir to say a few words on this occasion. Over to Dr. Amit Gupta. Can you stop sharing the screen, Vipul?
Good evening to all of you. And thank you very much, Professor Manjusha, for having me on this program, and it gives me great pleasure to join this webinar, which is organized by WIN India. And I'm extremely happy and delighted that WIN India has taken this initiative in restarting this monthly webinars, which was started by Professor Anita Saxena over the last few years. Anita was very passionate about this webinar and even continued organizing this program while she was receiving her treatment in the last few weeks of her life. Anita had realized well into the early days of her working period that nutrition is an area which is extremely important in the management of patients with renal disease. And this required a close collaboration and interaction between the clinicians and the nutritionists. And I'm really happy that WIN India is organizing this webinar. And the first webinar has been dedicated to nutrition, and the discussion will be on nutrition, the role of nutrition in the pre-dialysis stage. As you're all aware that most of us as nephrologists have very little knowledge about the nutritional importance of nutrition and how do we advise our patients. So with this webinar will help us in learning a great deal about it in a more scientific manner, because just prescribing certain food items is not enough. We need to know more about it and how we should individualize our nutritional therapy to our patients. So thank you once again for having it. And I'm really grateful that you had this special tribute paid to Dr. Anita, and I wish you great success. Over to you, Professor Urmila.
Good evening and namaste. I welcome all of you for this special session on nutrition dedicated to the memory of Professor Anita Saxena. Everybody has alluded and talked about her passion for nutrition and her professional achievements. I always looked up to her as a friend, and forgive me if I sort of spend a little more time about her, the personal qualities of her, which I think all the youngsters who are here today should emulate in some form or another. The first was her demeanor, always smiling, always gracious, and always dignified. She will always take everything with a positive way that she does. And it was just like that with her, we could make her, you are in control of your own emotions. That was the first quality which I tremendously lacked, and I could always relate to her and talk to her for getting some guidance and how to face or approach difficult situations. The next character of her, which I remember, was her helping hand. When we were all discussing as to how to take forward women in nephrology, she was the one I looked up to, because she had tremendous experience of starting an organization, running a journal, and continuously, successfully have an annual meeting every year, and every Sunday of the month organize a webinar. So she was the one who guided us. And of course, the third is her passion and dedication to her profession. The way she handled nutrition and the way she got nutrition into the mindset or in the consciousness of nephrologists was phenomenal. She made us realize the value of nutrition in our practice. And as Sir said, not just food items, how many eggs or how many alus or potatoes. She worked on assessment of nutrition on the cutting edge. Her publications are in Journal of American Society of Nephrology. Her work on finding out other aspects of nutritional manipulation in chronic kidney disease, everything. So that is her journey for us, for all of you, Jyoti Priya and others, is a journey of inspiration. How you start with a passion, don't leave it, do as much as you can for that profession and give your utmost. I miss her, and every day I wish I could talk to her and take this forward. So I'm extremely grateful to Priyamvada and her team to take this initiative forward. And we will in Women in Nephrology. She was one of our first executive founding members in nephrology, in Women in Nephrology. We will take her memory forward. And I encourage all youngsters to work and publish something in nutrition in chronic kidney disease. We are in our society are thinking of Manjusha, Swarlata, Manisha and others of dedicating a memorial lecture on her name from the next meeting on a work specific to nutrition. So all youngsters, the best tribute that you can give to her is not a webinar, but a consistent, continuous effort in making nutrition as important as it is for anything else in nephrology. Thank you very much. Thank you.
Thank you, ma'am. Thank you, sir. Now we'll move on to the academic session of the day. We'll be having highly informative talks on 3 different topics. We'll be having 3 talks, starting off with the role of bioimpedance in the nutritional assessment in pre-dialysis CKD, followed by talk on prescribing diet for pre-dialysis CKD patients, and subsequently our last topic, which will be on role of medical nutrition therapy in CKD progression. I would like to draw your attention to the fact that we will not be having question answer session in between the talks. Instead, at the end of the 3rd talk, we'll be having a session open for question answer discussion. So attendees can type their queries pertaining to each topics in the chat box, and which will be dealt at the end of the session. And now we'll be having a poll. I think Vipul. Yeah, kindly cast your vote, and this poll discussion will be taken along with the question answer discussion at the end of the 3rd talk. That is our final one. So please cast your vote for these polls, and we'll be having the discussion at the end of the session. And also please type your questions in the chat box. We'll be having a discussion on it along with this poll discussion at the end. So I think we can proceed to our academic session. Hope everyone had casted their vote.
I think Jyoti gave them some time limit, 1 minute or so, something like that.
I think we'll have 2 more minutes.
2 minutes is a long time.
Okay, fine. Thank you. So we'll move on to our academic session. We'll start off with the first talk, which is the role of bioimpedance in nutritional assessment in pre-dialysis chronic kidney disease patients. So for all the 3 talks, we'll have 4 moderators. So let me invite our moderators. For moderating the sessions, we have Dr. Arpita Roy Chowdhury, President of Indian Society of Transplantation, Professor and Head, Department of Nephrology, NBMCH, West Bengal. Joining her will be Dr. Anupama Kaul, Professor, Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. I also invite Dr. Meenakshi Bajaj, Dietitian, Tamil Nadu Government Multi-Specialty Hospital, Chennai, and Dr. Rajiva Lojana, Consultant Nephrologist, Madras Medical Mission Hospital, Chennai. Over to the moderators, and I request Dr. Arpita ma'am to introduce our first speakers. Over to you, ma'am.
Thank you, Jyoti Priya. And today's webinar is really special. And I think Arpana Iyengar doesn't need much introduction. She is quite known as a head of the Department of Pediatric Nephrology in St. John's Hospital, Bangalore. And she is a well-known teacher and mentor for many mentees around. She is working with International Society of Nephrology in various programs with lot of publications from her end. And today's talk is really special because we have looked at BCM as an important investigating modality to assess the protein energy vesting in dialysis section, but really using bioimpedance in pre-dialysis CKD. There is a lot to learn and share. I think I will not be any barrier to next 15-20 minutes talk. A great thing to learn from Arpana. Arpana, please, the stage is yours.
Thank you, ma'am. Good evening, chairpersons, WIN office bearers, Professor Amit Gupta. And I think I should first of all thank Dr. Priyamvada for including me in this session. I consider myself fortunate to have been associated with Dr. Anita Saxena. I have attended and benefited a lot from the workshops that she used to conduct every year. And she was kind enough to include me in the webinars, especially during the COVID time, as a part of SRNM activities. Today, we are here to discuss bioimpedance, which I still remember was a very important topic that Dr. Anita Saxena spoke about. She would share her experience with bioimpedance analysis with all of us. So the role in nutrition assessment in pre-dialysis CKD. So the title is a bit tricky because the guidelines, adult guidelines on nutrition clearly states that bioimpedance may not be a valid tool in pre-dialysis stages of CKD, but definitely has been recommended as a tool assessment of nutrition in patients on dialysis, that is especially hemodialysis. So to do justice to this topic, I take pride to introduce to you all my colleague, a young, bright, efficient pediatric nephrologist who was trained in us, Dr. Soumya Reddy. She has graduated last year as a DM pediatric nephrologist and has joined us as a senior resident in our department. And why I have invited her here is that she worked on bioimpedance analysis as a part of her thesis. Of course, the work is on children, but we are here to discuss the role of bioimpedance in both adults and children with CKD. So what we're going to do is now go through the basic devices, the principle of bioimpedance, give you more knowledge about what are the limitations and how bioimpedance is useful. I mean, we got to know both these aspects before one just jumps and takes a bioimpedance analyzer. It's such an easy bedside tool and starts, measuring these parameters in our patients. So to begin, it's always nice to look at our body as compartments. So let's take a peep into body composition. Body weight is made up of several compartments. If we have to look at two broad compartments, it's fat mass and fat-free mass. The fat-free mass is further divided into cellular tissue, total body water, and bone and other non-active components. So what we are interested here today, next, Soumya, please. So we are going to talk about bioimpedance analysis, and that is one of the, it's an assessment tool that provides us information about total body water. Now, it can also give us information about fat and fat-free mass, which we'll come to a bit later. So it can also give us information about body cell mass. So fat mass, fat-free mass, total body water, and body cell mass. Having said this, we all are aware of what is a reference gold standard tool. And let's be very clear at this point that bioimpedance analyzer is not a reference tool for fat, fat-free mass, or total body water. So it is, after all, a surrogate tool, but it is a convenient tool, and therefore it's been used and studied a lot as a bedside assessment tool. So we have other modalities of assessments for various body compartments, but that's not going to be our focus now. So we will now right away jump into bioimpedance analysis, and I request Samya to take us from basics to its role in nutrition and targeting dry weight. Samya, please.
Thank you, ma'am. I also would like to thank the organizers and my mentor, Dr. Arpana Iyengar, ma'am, for giving me this opportunity. So today in this session, we will be looking at some of the basics of bioimpedance analysis, the type of devices that are available, how to prepare a subject for a bioimpedance analysis measure, some of the limitations that are associated with the devices for bioimpedance measurements, a little bit on bioimpedance vector plots and their advantages as compared to the basic BIA. And the second half of the talk will deal primarily with the utility of BIA in clinical practice, that is with hydration and more specifically with nutrition assessment. So why do we need to choose bioimpedance analysis? With the advancement of technology in the medical field over the last few decades, bioimpedance analysis has gained importance in body composition assessment as a very valid and reliable tool. It is a safe, easy to use, non-invasive, portable bedside tool that provides information both regarding hydration and nutritional status. As ma'am has already previously spoken about the body compartments that can be analyzed with BIA, that is predominantly the fat-free mass, including intracellular water, extracellular water, and thereby composing of total body water, and also provides some information regarding body cell mass. Why it's important to know about BIA is that it's a highly reproducible tool which has been validated with the gold standard of isotope dilution methods. So how does BIA work? Well, it looks at the body as a composition of tissues which have electrical properties. So when a weak alternating electric current is passed through the body, the electricity flows along highly conductive body tissues, which are also called capacitors. The current can flow through two different mechanisms. One is directly through the body, through the fluid itself, or indirectly across the cell membranes. So when we actually pass a low frequency, that's around a 5 kilohertz frequency current, we can see that the current predominantly only passes through the fluid component and not through the cell, thereby giving us an estimate of the extracellular fluid or the extracellular water. The cell membranes, however, at higher frequencies will discharge these electrical currents. So when you pass frequencies of current of over 50 kilohertz, we see that the current passes not just through the fluid, but also through the cell membrane. So this gives us an idea of the intracellular and extracellular fluid, thereby giving us an assessment of total body water. One of the main important components that are assessed with the bioimpedance machines is that of impedance. Impedance is nothing but a force that prevents the current passage through it. It's given as a vector sum of resistance and reactance. We can think of resistance as a block to the electrical current, and usually resistance is represented as R. And reactance is the property where the electrical current stays within the cell membrane, and this is represented as Xe. So just to clinically validate these terminologies, resistance gives us an idea of the body fluid component. So the greater the amount of total body water, lesser is the resistance, whereas reactance provides information regarding the body cell mass. So this was about some of the basic principles and some of the basic parameters that are looked at in bioimpedance analysis. Now let's go on to some of the commonly used devices that are available. So whole body bioimpedance methods can broadly be divided into two major subgroups. One is bioimpedance analysis, or BIA, and the other major type or set of machines are the bioimpedance spectroscopy, or BIS. Bioimpedance analyzers are usually of two types. One is a single frequency, which only measures body composition parameters at a single frequency of 50 kilohertz. And the other is a multi-frequency BIA, which is more commonly used. The multi-frequency BIA has an advantage that it looks at a varied range of frequencies. That's between 5 and 1000 kilohertz. But here it looks at specifically only 4 frequencies. One is at 5 kilohertz, 50 kilohertz, 100 and 200 kilohertz. Some of the commonly available devices commercially are ones that are listed here. What we use at our center is the BodyStat QuadScan 4000, which is a multi-frequency BIA machine. The analysis is based primarily on empirical regression mathematical equations, assuming certain parameters such as age, gender, and race into these complex equations. The other part of the analysis also includes vector plots based on the resistance and reactance, which we'll be looking into later. From these analysis methods, we get the parameters from BIA, such as total body water, an assessment of the extracellular absolute volume, and the ratio that is looked at, ECW by TBW. We also get a certain amount of information regarding the fat mass and the fat-free mass. And specifically from the vector plots, we get more information regarding hydration and even an estimation of phase angle. Bioimpedance spectroscopy is different in that it's a superior tool where it looks at a wider range of frequencies between 3 and 1000 kilohertz. And this, in contrast to the multi-frequency machine, looks at multiple frequencies and not just 4 fixed frequencies. The commonest machine that is used is the body composition monitor, and it works on complex modeling principles of the Cole-Cole plot. Here as well, we get parameters of total body water, extracellular water, fat mass, and fat-free mass. But the advantage lies in its secondary analysis, where it looks at something called 3-compartmental model, where it gives us more information regarding the fluid status and also the body cell mass. It gives us parameters of absolute and relative fluid overload, fat-free mass index, lean tissue mass index, and adipose tissue mass. Now, coming to the two major devices that are available in the bioimpedance analysis, which is the single frequency and the multi-frequency. As I mentioned earlier, single frequency looks at only one single frequency of 50 kilohertz, and thereby it provides some information regarding the body composition. So it does not accurately predict or estimate the total body water, and it has a lot of fallacies when used in conditions of abnormal hydration, especially in CKD patients. In contrast, the multi-frequency BIA studies body composition at various frequencies, and it more accurately estimates the extracellular water, the total body water, and also the fat-free mass. Here, specifically about the ECW and ICW, the total body water looked at 200 kilohertz gives us more accurate information. And these multi-frequency devices are what are commonly used in clinical practice. Now, compartmental models, the classical or the older devices use the 2-compartment model, which is also being used with the multi-frequency BI. The 2-compartment model is nothing but looking at the entire body in 2 separate compartments. One is the fat-free mass and the fat mass. Thereby, the information that you get is not very precise as compared to a 3-compartment model, which is what the body composition monitor, the bioimpedance spectroscopy machines use. Here, they provide additional information regarding overhydration, lean tissue mass, and adipose tissue mass. And why this is important is that when you just use a multi-frequency BIA, your nutritional parameters get influenced by the hydration status. So if a patient is over or underhydrated, there will be an under or overestimation of the nutritional markers, especially in CKD patients. So bioimpedance spectroscopy is a much more sophisticated device that is available as compared to a multi-frequency BIA, but is also more expensive and not very easily available or accessible to centers like ours. Bioimpedance spectroscopy, as I've mentioned before, does not depend on the regression equations, but instead looks at body composition parameters of resistance and reactance when it's plotted at multiple frequencies. This is called the Cole-Cole impedance plot, which helps derive the parameters that we need. So instead of looking at either a single frequency or 4 fixed frequencies, it uses a composition of close to around 256 frequencies and thereby gives us varied values. The most important of which, especially for hydration measurements that have been validated, are that of overhydration and relative overhydration. For nutrition, the parameters we'll be looking at in subsequent slides. So the machine that we commonly use is that of a multi-frequency BIA, which has the multi-frequency impedance measuring unit. It comes with disposable hydrogel electrodes and the red and black cable leads, which are of a specific length to be able to measure accurately. Some of the prerequisites for performing a BIA are that usually it's contraindicated in early pregnancy. And even in late pregnancy, they say that the values are not really very reliable and not known to be clinically important. So it's better to avoid doing BIA in pregnant women. Some devices also have a caution when a patient has an implantable electrical device, such as a pacemaker. Some devices also have cautions when there are metallic objects like pins or stents that are there. Prior to performing a BIA, it is best to ask the patient to avoid exercise 12 hours prior to the test, to be fasting for at least 4 to 5 hours prior, and to avoid consumption of both alcohol or caffeine in 24 hours prior to the test. So once the patient is set ready for a BIA, we need to take in demographic details, especially of age and gender, and anthropometric measurements of height, weight, hip circumference, and waist circumference. The patient needs to be resting prior to the test being performed. So usually the recommended posture is of supine with most of the machines that are used. Newer machines also have a standing or a sitting posture that can be adopted. In a supine posture, the patient is asked to lie with hands, with the palms facing downwards and with the limbs apart from the body. And if there are any metallic objects, to be removed in the passage of the electric current itself. The electrodes are to be placed and then the patient is asked to rest for 5 to 10 minutes. And in patients who have peritoneal fluid, either on APD or CAPD, it's ideally recommended to drain the peritoneal cavity and keep it empty prior to the measurement. And if that is not possible, then to subtract the estimated volume of PD fluid from the body weight itself before entering it into the machine. The most crucial step of performing a BIA is in the placement of electrodes. So the electrodes are self-adhesive, disposable hydrogel electrodes. We usually use the 4 electrode placement, which is a pair on the right hand and a pair on the right foot. Usually the right side of the body is preferred because most recommendations are that to avoid left side of the body, to avoid passage of electric current through the cardia itself. So once the electrodes are placed, the red lead is the injecting or the current lead. And this needs to be connected to the electrode that is placed just behind the knuckle and behind the toes. Whereas the black lead, which is nothing but the sensing lead, is connected to the electrode that's placed on the wrist, that's at the level of the ulnar head, and on the foot at the ankle between the medial and lateral malleoli. It's very important to ensure proper connection of these, both the placement of the electrodes and the connection of the leads itself, because this could significantly distort the measurements that are taken. Now we have a small video of how we've performed a BIA measurement on one of our patients. So once the machine is switched on, the demographic parameters, that's age and gender, are entered, and measurements of height, weight, waist circumference are also entered. Once parameters are entered, the message up on the monitor is to connect the electrodes. This is when the cables need to be connected, and the electrodes are placed on the patient. So here you can see this is the 4 electrode placement. That's a pair on the right foot. That's one that's placed just behind the toes and one at the level of the ankle. And the other set of electrodes, one that is placed on the right hand just behind the knuckles and the other at the wrist. So once this placement is done, it's again important to connect the leads properly. So the red is the current or the injecting electrodes, and these are connected to the ones that are just behind the knuckle or the toes. And the black is connected at the level of the ankle and the wrist. Once the electrodes are connected, we can press start on the machine so as to start the measurements of bioimpedance itself. And once the measurements are done, there is usually a message that appears saying the measurements are complete, and these electrodes can then be disconnected. So the values are either accessible on the monitor itself, or there are softwares that are available that can be installed on any computer, and you get an entire strip of parameters. The previous machines actually had a printed slip that used to come right away and not have a software where there was a storage of these values, but the newer machines all have a stored value strip that comes. So the measurements that are usually captured by the bioimpedance analyzer are that of weight, height. It gives us information about the fat mass, the lean mass, the total body water, extracellular, intracellular water, and more importantly about resistance and reactance. Now that we've known about what BIA is and what it can do, we also need to be aware of some of the important limitations that are associated with bioimpedance analysis. One is that it's based on the assumptions or empirical mathematical equations which can distort your measurements, especially when you're looking at a population that's not in the reference or standard population itself. The other, as I mentioned, is single frequency will underestimate the total body water. It makes an assumption that the entire body is like a cylinder. But the assumption is wrong because the trunk, even though it's around 70% of the total body weight, will only contribute to around 10 to 20% of total resistance, and limbs account for a larger amount of resistance. The newer devices actually look at the body as a 5-segment or a 5-cylinder model, where limbs, trunk are taken as separate parameters or entities. And the other is when the electrodes are placed not in the recommended places, then all the values are going to be fallacious. To overcome these limitations, Piccoli in 2004 came up with the bioimpedance vector analysis, which is nothing but a graphical representation of impedance, which is as a vector with a magnitude and angle based on body composition. So this overcomes most of the limitations associated with the bioimpedance analysis. It gives us a pictorial representation of the hydration and nutritional status, and also helps to track an individual's hydration or nutritional status over time. So how are these BIVA plots created? When you have measurements of resistance and reactance, these are standardized by indexing them to height. So you have resistance by height and reactance by height. And to make them more uniform and standardized, these are then converted into bivariate Z-scores. Once we have these values, tolerance ellipses, which represent the 50th, 75th, and 95th percentile of the impedance vector, which are distributed on a selected reference population, are plotted. The softwares that are commonly used are the R software, and it can also actually be done in Excel, which is more easily accessible to us. So you plot the Z-score of resistance by height on the X-axis, and on the Y-axis, you have the Z reactance by height. The values of the reference population are plotted corresponding to the 50th centile, the 75th centile, and the 95th tolerance ellipse. Values that are are abnormal if they lie beyond the 75th tolerance ellipse. Now that we have these 4 quadrants that are created, overhydration is nothing but values that come in the left lower quadrant beyond the 75th tolerance ellipse. Whereas decreased body cell mass is the right lower quadrant beyond the 75th tolerance ellipse, dehydration in the right upper quadrant, and increased body cell mass in the left upper quadrant. So given this very simple pictorial representation, it's very easy to be able to assess both the hydration and the nutritional status in a subject or a patient. And it also gives us a way to track their progress over time. At our center, we've created reference plots because these are not really available for children. So using 50 control subjects, we have created gender-specific reference plots, one for girls and one for boys, using the standardized Z-score resistance and reactance curves. And we are using these very often in our clinical practice, especially in our dialysis patients, to look at both hydration and nutritional assessment. Now that we know something about BIA and BIVA, we need to know about what its clinical applications are, especially in chronic kidney disease. Most studies in literature have looked at those on dialysis, where BIA is used as a guide to alter or titrate prescriptions so as to avoid both hydration and overhydration, which are both known to impact cardiovascular morbidity and mortality. In other CKD patients who are not on dialysis, they can also be used as a monitoring tool for those who have issues with fluid control, who are on diuretics to titrate these medications, and obviously as a nutritional assessment. It's also used to predict the risk of heart failure and has been proven to be superior both to clinical tools and to other modalities of hydration assessment, especially that of lung ultrasound in early detection of subclinical overload. Very briefly about the role of bioimpedance analysis in hydration. So bioimpedance analysis either gives you values of absolute volumes, ratios, or plots, whereas bioimpedance spectroscopy is mostly looking at absolute values and ratios. The measures that are highlighted in green represent the validated measures both in adults and children. So in the one tool that is common to both adults and children and that can be used, and we have ourselves noted to have a great deal of importance in hydration assessment, is that of the BIVA vectors itself. Some of the factors that can affect measurement of the hydration status is obviously that of nutritional status, and this can be overcome by using BIVA. And hypoalbuminemia has also been known to influence hydration measurements, but more recent studies have said that it's not a significant association. So now that we've looked at some of the important parameters that are looked at with hydration, are these actually validated? And what is the actual role of BIA as per evidence? So most studies have been done in dialysis populations, more commonly in HD than in PD. And in hemodialysis patients, all three tools, that is bioimpedance analysis, BIVA and BIS, are all known to help at least reduce the risk of hospitalizations, reduced all-cause mortality, and be an important tool for measuring both hydration and nutritional status. The evidence in peritoneal dialysis patients is a little inconclusive. Some studies have shown that they do help in improving the fluid overload status, but using them as a long-term or especially for longitudinal measurements is still yet to be proven. In children as well, most studies have looked at bioimpedance spectroscopy to look at both the hydration and nutritional status.
That was wonderful, Soumya. So we'll now look at some of the examples that we have on clinical bedside assessment using BIVA. So by now, I think we are clear in highlighting the advantages of BIVA over BIA that provides us both hydration and nutritional assessment alongside each other. So this is the first plot, the reference plot that we had created with a smaller number of control subjects, and we took few patients on hemodialysis, and you can see how the points are shifting. So if the point was down there, the short arrow, that was overhydration status. And over time, not just with one hemodialysis session, but with a couple of them. So it's like a serial monitoring going on. And probably after 4 or 5 sessions, we actually were able to bring the dot into the reference curve. So which means it is normal. So this is equal to dry weight. So clinically, we always assess dry weight in a very arbitrary fashion, but this would be a more objective way of assessing dry weight. So here is an example of a 14-year-old girl on chronic hemodialysis, and you see the pre-dialysis and post-dialysis weights here. And if you do a BIA analysis, you get resistance, you get reactance, and what we do is adjust it to height, especially in children, and therefore you get resistance by height and reactance by height, and these values are plotted, next slide, are plotted on this reference curve, wherein you see the pre-dialysis weight at 46.2, and you have a dot there. So clearly it is within the overhydration compartment. Post-dialysis with 2.2 kg of UF, 2.2 liters, or weight loss by 2.2 kgs, the dot goes up there, but still it is outside the 75th centile, which means that there is still overhydration. And then another session where the weight comes down to 43 kgs, and when the values are plotted, you can see that the dot goes well within the 75th centile, which probably we could take it as the dry weight. The clinical weight was 44, but objectively the dry weight would be 43. Now that's important because today we're talking about nutrition, so it's important to get to know the dry weight when you're assessing a nutrition status. So the parameters that are provided by BIA, the multi-frequency one that we use in our center, would be fat-free mass, body cell mass, body fat, phase angle. And of course, we can plot the Viva reference plots. In contrast to this, the bioimpedance spectroscopy will give additional parameters that you see here. But of course, we have not had experience using this tool. Next slide. And this gives an overall view of various parameters that you can derive from BIA, like fat-free mass, fat mass, and you index it to height and you call it fat-free mass index, fat mass index. Very important in children because children with CKD are short. So you always want to adjust your parameters to height. And of course, we have already learned, Soumya has highlighted this earlier, that tissue hydration is a big limitation of bioimpedance analysis, whereas what you see in the red color are parameters that are derived from bioimpedance spectroscopy, and that is independent of fluid status. So if at all you need to use a bioimpedance analyzer, go in for a BIS, or that it's also called body composition monitoring tool. So you can get various parameters of lean tissue mass, adipose tissue, lean tissue mass index, and body cell mass. So these are the nutrition related parameters that are derived from these two devices. Next slide, please. And there are various studies. This is a nice recent review which was published in Nutrients that talks about the utility and scope of BIA in patients with CKD, and they highlight the various studies that have been undertaken thus far, highlighting the bioimpedance parameters like lean tissue and fat mass being correlated with various other nutrition-related indices, quality of life, hospitalization, mortality, and phase angle, which I'll come to in a bit. Phase angle and its relationship or association with inflammatory markers, hypoalbuminemia, PEW status, and mortality. And of course, the 3 columns you see is that all these studies have been undertaken in pre-dialysis, HD, some in PD, and some in transplanted patients. Next slide, please. So if I have to just mention whether when you look at body fat analysis in pre-dialysis CKD, how does bioimpedance help us? This study here showed that skin fold thickness had a better agreement with DEXA, because you take DEXA as the gold standard for fat mass assessment. So skin fold thickness fared better than BIA in terms of agreement with the gold standard. Next slide. What did we find in children? So we set out to look for body fat assessment. We used BIA, that is the multi-frequency BIA versus DEXA. And we looked at 33 children with CKD 2 to 5, including few on dialysis. And as you can see here, next, as you can see here, the body fat mass was reduced only in 18% derived by DEXA and 12% by BIA. So though we see our children quite skinny and undernourished, emaciated, the body fat mass is preserved. And this is a known phenomenon in children or adults with CKD. These two Bland-Altman plots kind of, reinforce the fact that the agreement is quite wide. There are wide limits of agreement between the BIA and DEXA, and BIA overestimates the body fat by 3.5% compared to DEXA. So this is a very important message, because when we use these tools, we got to know how accurate they are and what are their limitations compared to the reference tool. Next slide. Then we set out to look at phase angle. I remember Dr. Anita Saxena kept telling us the importance of phase angle in her patients. So she would say that if the phase angle, they would do a screening BIA in the ward, and if she would get a phase angle as low as anything less than 4, sometimes 2 and 1, she would say, she would know definitely this patient won't make it. And she would tell us that that was one of the important screening parameters that could predict mortality in her patients. So we looked at a cohort of patients who had PW and who did not have PW in both CKD 2 to 5 and children on dialysis, and looked at the mean phase angles in these. Of course, the phase angle was lower in those with PW in both these groups. And then we looked at, is there really a cutoff of the phase angle? Next, please. So both in both the groups, if you see, we looked at the AUC curve and derived a cutoff of less than 4.3 degrees to suggest whether a patient has PW or no. And this is, of course, in children. So that gave us a specificity of 85%. And in those on dialysis, the cutoff was less than 2.9 with a sensitivity of 73.3 and a moderately acceptable specificity. So, of course, this cannot be extrapolated to larger group of patients, but this is the finding that we had. And I urge clinicians and nephrologists and youngsters to use bioimpedance spectroscopy or BIVA in your patients and study these findings and observations. That would probably help us, add to the existing limited evidence that we have from our region. Next slide. And the last part is the body cell mass. Now, body cell mass, I told you, is an important metabolically active compartment of the body. It is the oxygen consuming part of the body, and therefore it would actually be the most ideal parameter to suggest good health and healthy cells in the body. So this can be derived or estimated by a reference tool called the whole body potassium counter. And I have done some work on this in the last few years. And we looked at the body cell mass derived from BIA and the body cell mass that was estimated through the gold standard. And again, as you see here, bioimpedance analysis overestimated body cell mass by 6 kgs, which is definitely not acceptable. So in both groups of dialysis, children on dialysis and the non-dialysis children. Next, please. So if you look at if you look at bioimpedance and an analysis, we have to be very careful to choose the right tool. The KDIGO guidelines for adult nutrition assessment recommends the multi-frequency BIA, but we have already learned that there are some limitations that can be overcome by using bioimpedance spectroscopy. But it's a simple, having said that, we know we do have limitations. We know that it is sometimes independent, dependent on hydration status, but still, because it's such a simple bedside tool, it is here to stay. We cannot get away or keep it aside and say it's of no use. So we may have more and more advanced tools coming up with better mathematical models and predictive equations. And this in adults is definitely validated and recommended, but in children it is not recommended. It's just recommended as a supportive assessment tool. So we have to remember that the BIVA, which is derived from the BIA, helps us to track dry weight by longitudinal hydration assessment, and also gives us the nutritional status, because you also look at the point that falls in the quadrant of low BCM. And I would be very happy if to share the actual process of getting these reference graphs for your population, because you need those graphs to plot and interpret the BIVA points in your patients. And I think if many of us start studying this, we'll have good body of evidence to suggest a very systematic and objective way to look at both nutrition and dry weight assessment in our patients. Thank you very much, and we'll be happy to answer questions in the end.
Thank you, ma'am. Thank you, Arpana ma'am and Dr. Soumya Reddy, for that excellent overview of the bioimpedance assay. Thank you so much. So we'll move on to our next session. Our next topic is on the prescription diet prescription in pre-dialysis CKD. For that, I request Dr. Meenakshi ma'am to introduce our next speaker. Over to you, ma'am.
Thank you so much. At the outset, I'm truly grateful to Women in Nephrology for the opportunity to be part of this important seminar, which has been a tribute to none other than Professor Anita Saxena ma'am. And she's obviously been very, very passionate, not only about nephrology, also about renal nutrition. So truly, it's an honor. Thank you so much. And with reference to prescribing a diet, it's truly a challenge. We all know that all our CKD patients with dialysis walk into protein energy wasting. And with pre-dialysis state, where we have uremia, we have phosphorus, potassium, sodium fluid, all of them surrounding us with restriction, we assume that the diet needs to be restrictive. But then I think we have none other than Ms. Sunita Rao, a good friend of mine and chief nutritionist of NU Hospital, who has, to her credit, about 15 years in the field of clinical and therapeutic nutrition. Currently, she's heading the NU hospitals with reference to nutrition department, and she has, to her credit, a gold medal both in her UG and PG. She's also an SPEN LLL certified with reference to ICU nutrition, a certified diabetes educator, certified in FODMAP by Monash University. And the most important thing, she not only just handles clinical renal nutrition, but she's also very, very passionate about passing on the message for the population, for the CKD population, by contributing to several series of booklets with reference to known as Nutritional Secrets, a patient education series for CKD, dialysis, and post-renal transplantation. She's also currently the honorary secretary of IAP in India, Bangalore chapter, the executive committee member, Indian Dietetic Association, Bangalore chapter. Without much ado, I would request Ms. Sunita ma'am to take over the session and talk to us from theory to practice. Truly a challenge.
Thank you, Meenakshi. Thank you for the warm introduction. And I would like to thank the organizers of WIN India and Dr. Priyampada for having me here today. And also my short tribute to Dr. Anita Saxena, who never said no to any of the doubts or help that required. The very first time I met her, I realized how much we had to learn from her. We all flocked to her for every small doubt, and she never said no. We miss her a lot, and her teachings, I think, will be always there with our fraternity. So today I will be talking about prescribing diets for the
প্যারামিটারগুলো
pre-dialysis
সব ভালো হয়েছে
patients.
ক্যালসিয়ামেরটা শুধু এরকম বিশ্বাসযোগ্য নয় মানে এই পস্টারটা
Can we
আগেও
have
দেওয়া
all the attendees mics?
Arpita, can you
Okay.
mute? Arpita, mute yourself.
Um,
Thank you.
I request all the
Yeah.
attendees to mute the session.
Yeah. So why do we need a diet prescription in the pre-dialysis? For example, for that matter, for any CKD patient. So it is basically to see whether they are getting adequate calories, whether they are getting adequate proteins, neither excess nor inadequate, to maintain the muscle mass, to support their immune system, to help maintain a fluid balance, to help electrolyte balance. And most important of all, when we are talking about this pre-dialysis population, where we probably, if we are lucky, we get to see them in the early stages of CKD too, but otherwise, by the time we see them, they are already in 3 or 3B stage. So in the early stages, the most important factor is to address the underlying comorbidities like the diabetes or the hypertension. Now, we all know that eating becomes a challenge as the CKD progresses because of anorexia, inflammation, metabolic acidosis, endocrine disorders, when there is insulin resistance and impaired response to IGF-1. The comorbidities, as I mentioned, and also they are into psychological issues like depression, loneliness, physical inactivity, and there could be an underlying economic burden. Now, most importantly, if you look at most of the National Kidney Disease Foundation or anything, they talk about prescribing diets similar to Mediterranean diets or to DASH diets for patients who are in the pre-dialysis population. So what would happen is in the first 2 stages of CKD, where the emphasis is on treating the underlying disease like the diabetes or hypertension, the DASH diet and the Mediterranean type of diets would definitely help. But then as the disease progresses, we have to look into various other factors that we will be seeing now. Now, this is a very old slide, and I often like to come back to this slide to remind myself of all the complexities that this disease has, so that when it constantly reminds me of why this patient needs to be addressed to when I look into their issues. So now, as I said, in the first 2 stages, it is mostly the underlying comorbidities. And then when the CKD progresses, the management of electrolytes, the long-term management of phosphorus, especially in pediatric patients, and the protein monitoring and the fluid balance come into play. Now, we always start with nutritional assessment. I'm not going to be dealing with nutritional assessment in detail, but how important it is. Most of the time, all our nutritional counseling and prescription will start from the nutritional assessment, all the time. And it's the key factor in determining the patient's needs. And we all know protein energy wasting is a very strong indicator of mortality in CKD. The nutritional assessment for CKD patients is always a combination of various measures rather than a single measure alone. Just now, we went through a wonderful session of how to use BIA for nutritional assessment. Along with that, we have other nutritional assessment techniques which we take in conjunction to finally form our views or our recommendations in prescribing a diet. Now, for example, in many of the patient populations that we see, the serum albumin levels will be quite good. It will be around a little less than 4, but around 3.9, 3.7. So most of us would think that, oh, fine, they are doing well. But then when you look at their dietary history or a diet recall over a period of time, you see that their diets are really poor. So it's always important to take things in conjunction. In this pre-dialysis population, the disadvantage we as nutritionists have is that we don't get to see them very often. We see our dialysis patients very often because they are there at the center every alternate day. But here in this population, they're lost to follow-up most of the time. And if we could actually follow up with them every 3 months to check if their serum albumin levels are maintained, and take their subjective global assessment with respect to all the sub 8 parameters that are there in the subjective global assessment, take their dietary interviews, and if the patient can maintain a diary, which seldom they do, if at least a few of these parameters are met and assessed every 3 months, it gives us a very clear idea as to where the patient is heading to and how we can correct their diets to improve their nutritional status. Now, on the whole, if we talk about the nutritional assessment, we have to remember that it is crucial. A follow-up is very crucial, and the patient should understand that from the early stages of CKD to the CKD stage 4 or 5, the diet will not remain the same. It may not remain the same, and so they have to modify the diet as the condition progresses. So each diet has to be personalized, and so communicating all these points to our patients is absolutely important. Now let us look at the macronutrients. The recommendation by the KDOQI is very similar to what we have in our healthy subjects. 35 kilocalories per kg body weight under the age of 60, 25 to 30 kilocalories per kg body weight over the age of 60. When the patient is metabolically stable, that is, they don't have infections or they're not ICU patients, basically. And so if I have to give an example, if there's a 55-year-old female patient with diabetes with a height of 163 and a weight of 67 kgs, if you start with a calorie requirement of 25 kilocalories per kg body weight, 1,500 kilocalories would what you would start with, and then maybe increase or keep it stable based on how she would progress with respect to her maintaining her weight or need-based. Here, in this case, it would be just to maintain her weight, and we would not want her to lose any weight. Now, another point about energy requirements is most of the carbohydrates that we use to make up the calorie requirement of our patient would actually have to be distributed over a variety of carbohydrates, so that they can get the advantage of glycemic control as well. Now, moving to the most important aspect of our diet prescription, that is the protein prescription for a pre-CKD, pre-dialysis patient. Now, what does the guidelines say? When there is a patient without diabetes, pre-dialysis patient, they say give about 0.55 to 0.6 grams of dietary protein per kg body weight. This is for non-diabetic patient. And if it is a diabetic patient, you can increase it to up to 0.8 grams per kg body weight to maintain or optimize the glycemic control. This is as per the KDOQI guidelines. Now, we will move forward and see what happens. Now, also, why do we require a protein restriction? Why are we, first of all, talking about protein restriction in our pre-dialysis population? When kidney functions declines, we know that there is an accumulation of uremic byproducts, and these byproducts, especially the p-crysyl sulfate, indoxyl sulfate, trimethyl amino oxide, and fibroblast growth factors 23, all these, which are the byproducts of animal protein metabolism most often, start accumulating as uremic toxins, and protein forms the major workload for the kidney. So clinical research has confirmed the deleterious effects of the renal hyperfiltration response associated with protein intake. So by reducing uremia and uremic toxins on one hand and improving the renal hemodynamics on the other hand, we can postpone the need for maintenance dialysis and increase the life of the failing kidney. And these are as per I'm quoting the KDOQI guidelines. Now, also it says that when you have to calculate your protein prescription for this population, it is neither whether you want to take the ideal body weight, BMI, or the usual current or the adjusted body weight. This is as per the clinician's judgment based on the patient's health goals. And the specific weight formula used for the prescription should be personalized for the patient. Now, let us take a look at the Indian scenario. The KDOQI guidelines speaks broadly of the requirements for the Western population. Now, what happens when we look at patients from our country? The average protein intake of an Indian itself is 40 grams per day. And in most women, it could go lower than that, 35 grams per day. And with anorexia and other nausea and other CKD symptoms, it could be worse. Then the quality of protein that a patient is consuming is often poor. Then there is already a high degree of pre-existing malnutrition in patients who are diagnosed, which is diagnosed during the nutritional assessment. A detailed nutritional assessment is thus so important. There are myths surrounding the protein intake, and many stop eating all the sources of protein when they are diagnosed of kidney disease. So many of the patients who come to us for second opinion, or they would have already done a little bit of research on the diet for their disease condition, they would have stopped many of the protein sources. Either their healthcare provider would have told them to stop all proteins, but then somehow they're not able to stop the red meat as such, because probably they love to have that and they just cannot give up completely. But lentils, they say no. Sometimes only dal pani is consumed. Dairy is completely avoided. There is some major enmity for the dairy products. Then the patient is restricted to a diet that is mostly carbohydrate predominant and does contain fat. Now, another major factor that is coming up in planning protein requirements for CKD patients is this Play-Doh diet, that is the plant-dominant protein diet, which they say is used in the early stages of kidney disease. It helps to keep the healthy, it helps to maintain healthy weight, decreases BP and cholesterol, so it reduces the risk for diabetes, improved antioxidant levels, slows down the progress of kidney disease. Now, as we all know, that plant-based proteins shift the proteolytic profile to the saccharolytic profile. They promote the short-chain fatty acids. They strengthen the intestinal barrier integrity. They reduce the bacterial translocation. They reduce inflammation and improve overall immunity. So they reduce the production of these key uremic toxins, and hence they kind of slow down the progress of CKD. Now, on the other hand, it is said that animal proteins favor the proteolytic bacteria and thus cause dysbiosis and increase the progression of kidney disease. So there are also other benefits of plant-based diets. Though they are high, when you look at the value of phosphorus in plant-based proteins, they are on the higher side. However, their absorption is very much reduced because of the presence of phytates and the fiber as such. So the utilization of plant-based protein in CKD may actually generate fewer uremic toxins. So now, if you actually look at this Indian scenario that I just mentioned a few slides ago and assess all these all the recommendations that are now coming up, if you look at an Indian diet, it is already a Play-Doh diet. That is, it is a plant-dominant diet. Even the non-vegetarians don't consume as much non-vegetarian food or meat for that matter on a regular basis. So when you are actually assessing a patient, that is the reason, again, I stress, that is the reason taking a detailed dietary history is so important. You get to know how much of the protein is coming from animal sources and how much of the protein is coming from the plant sources. If you look at the population, most of them would be already on a Play-Doh diet. They might be actually on a lower protein diet than what is actually recommended, and you might have to include a good bioavailable protein like egg whites, portions of lean meat to improve their nutritional status, since they are, as I said, they are already malnourished when we see them. Of course, whole grams and lentils are definitely a staple of the Indian diet, and a rice and lentil combination will also give us the protein that is required. The only thing that I would say we have to monitor when we look at people, when we recommend eating lean meat, is to monitor the way they cook it, because the Indian method of cooking lean meat would always include plenty of sodium and other undesirable electrolytes. So I just included a couple of slides from one of the case studies that we did. We had a 55-year-old man who was on conservative management for CKD. He had come here for a second opinion, basically. And when he came, he was walking with a walker, or he would often lean on his son. Basically, he could not stand. His lower limbs were wasted. He was a scientist by profession. I would like to mention that. He was otherwise doing well with normal electrolytes. On diet recall, we realized that he had avoided all sources of protein as had been advised by him, to him by his healthcare team, and no dairy products, and occasionally he ate egg white. That's it. His height was 172, weight was 62 grams, and it was a difficult task to convince him that we had to introduce protein into his diet. Nevertheless, he being a scientist, somehow we were able to manage and convince him, and we started with a 0.8 gram kg per body weight. And we also had to warn him that suddenly if the creatinine increases a little, it does not reflect, he should not be scared, or just first initially bringing his nutritional status to some kind of a balance was very important. Then we introduced lentils and small amount of unprocessed dairy and cooked egg whites. He was not a meat eater, so it was cooked egg whites that we introduced. Electrolytes were not a big problem. We could adjust it on need basis. The diet still remained a carbohydrate dominant diet, but then 0.8 gram of kg body weight protein did wonders. And within 3 weeks, 3 months, he came back to our OPD often for follow-up, and he was able to walk without support. And he did well for a long time. He was already on in an advanced CKD stage. So he underwent transplant and he's doing well now. We also made sure that the calorie requirement is met to a proper extent so that the proteins are utilized completely. Now let's move on to the electrolytes that we have to take care in advanced CKD, basically sodium, potassium, and phosphorus. Now let us look at sodium. What does KDOQI guidelines say? They say 2.3 grams per day, which is a little less than 6 grams of salt, basically. So sodium regulation is required for two purposes, one for blood pressure and the other for proteinuria. And here we restrict salt to 4 grams. Salt, not sodium. So salt to 4 grams, so that the other sodium comes from the food that they are eating. The natural sources of food, sodium, compensate for the remaining aspects. So there is nothing much we can actually do to change the salt scenario. We only, of course, tell them that they have to get used to this low level of salt, and then they also have to avoid these special salts like low sodium salts, rock salts, pink salts. Their use has somehow increased these days, probably because of the various advertisement gimmicks that come up. So we have to be very wary of telling them not to use any other salt, because all these come with extra potassium and other minerals that could be undesirable. Now, let me move on to the potassium requirement. So in adults with CKD stage 3 to 5, what the KDOQI guidelines recommend is that maintain a dietary potassium intake so as to maintain a serum potassium within the normal range. So they have left it to individualize each patient's potassium requirement so that, it is not like a blanket restriction. It is based on the case. Now let us further see. Now we all know that when a patient suddenly goes into acute hyperkalemia, this is a case where generally we see in the ER, we do counsel for the low potassium diets here, but then it takes a while for them to get used to that. Also, when there is chronic hyperkalemia, we also have to look for underlying constipation. Most of these patients, since they are on a diet which is poor in fiber, will have chronic constipation, which also needs to be addressed so that there is a good clearance of potassium from the bowels, and this helps. And also, as we were speaking about the Play-Doh diets and their advantages, having a good fiber in their diet plays a very important role, not only in reducing the uremic toxins, but also in managing the potassium. Now, it is also very important, because we don't see these patients very often in the follow-up. We have to include a teaching wherein we have to teach them about the symptoms of hyperkalemia, and also tell them to read to learn to read their reports, where the safe zone is 3.5 to 5, and then the caution zone is 5.1 to 6, and then if they are already above the 5, they better contact the renal care provider immediately. With this information and the requirement for diet prescription, which is a little restricted with potassium, this forms the basis for the renal diet for every patient. Now, in the early stages of CKD, potassium restriction may not be required at all, and it is not like a blanket potassium restriction. It is on the need basis. So most of the time, if the allowance is somewhere around 40 milliequivalents of potassium, what we do is, when we plan the diet, we allot the main the potassium requirement for the main food groups, like the lentils, the carbohydrates, and the vegetables, and a little bit of dairy, so that these major food groups that actually provide the required protein and energy, the macronutrients, are taken care of, because we cannot compromise the lentils, the eggs, and the carbohydrates. The cereals form the staple of an Indian diet, and hence we first relegate potassium allowances for these food groups, and then up to 30 milliequivalents will be taken up by these food groups, and the remaining 5 or 10 milliequivalents can then be looked into for including foods of the patient's preference. For example, if it's a patient from Kerala, they would want to have a little more of coconut in their diet, or if it's a patient from West Bengal, they would want to have their own food choices. So we always keep a small portion of the potassium allowance to satisfy the patient's personal preferences, so that the diet is, they follow the diet, or they stick to the diet for a long time. Now, the diet guidelines for potassium, based on the observation, any average normal diet that you and me have would have around 8,000 mg or 8 grams of potassium per day. And it is a challenge to bring down the prescribed amount when potassium restriction is required. The right choice of fruits, vegetables, cereals, meat, and dairy in the appropriate portion sizes. The portion sizes are also very important, just not the selection of foods. They form the key in potassium management. Most often, there is a myth that it's the fruits and the vegetables that are the only sources of potassium, whereas most of the food groups do have foods, particular foods that are really high in potassium. You have to identify those food sources. And as renal dietitians, we already know, we have extensively searched the Indian foods and made lists of foods that are high, medium, low, and very low in potassium values, so that we can help our patients with not much of restriction, but still continue, but still manage potassium within the normal range. So the potassium content of the food depends upon the soil that it is grown in, and that is the reason most often, if people look for internet values of many of the foods that we eat in India, they may not be the right potassium values for those foods, because the soil often influences the potassium content of each of the food that is grown in our country. So it is best to give your chart, which is based on the Indian composition food tables, to make sure that they manage their potassium well. Now, we often talk about leaching. Let us see what this is. Leaching is often done to reduce potassium, and also we know potassium is a water-soluble mineral, and it just gets dissolved in the water. There are two ways in which you can actually do the leaching. One is to soak the shredded or the food particles that are cut in smaller sizes and soaked in warm water for half an hour to 1 hour, and then discard the water and cook it in fresh water. The other way is to boil the food in large quantity of water and discard the water, boiling water, and cook it and incorporate the food into the cooking. In whatever way you leach, we don't have a specific, we don't know how much of potassium is actually getting leached. We don't have the values of all the various foods that come after leaching. And most often, the way you leach, the amount of water that you add for leaching, the time that is taken for soaking the food product influences the final potassium value of the leached product. So leaching has a few disadvantages. It renders the food very tasteless and less nutritious. Let me tell you, most of the patients who come back after having leached vegetables for a period of time say that they stop eating vegetables, they stop eating food, they don't have any interest in having their meals. This is one of the major drawbacks of leaching. Leaching only works well with roots and tubers, but we don't know. In case of green leafy vegetables and other vegetables where the potassium values are really high, we don't know what is the end product, the amount of potassium in the end product. So as I said, again, leaching methods vary, and most often all your CKD patients who come especially in the early stages of CKD may not require leaching. So leaching is not a blanket rule for every CKD patient that walks into your clinic or for nutrition counseling. So based on their dietary pattern, based on their food recall, and based on their serum potassium values, you can always regulate their high potassium sources to fit into that 40 to 50 milli equivalents when leaching may not be required at all. So we all know that pulses have a lot of potassium, but they are the staple of Indian food. Now, when I was talking about protein requirement, as I mentioned, as such, our patients are already malnourished and protein and energy wasting is rampant. And just because we have to restrict potassium, we cannot restrict pulses. That forms the staple of every Indian meal. So only thing is, if we advise them to use whole lentils, which has a coat of skin on it, soaking overnight and draining it and then cooking it helps a lot in managing the potassium and still preserves the nutritional value. Dairy is another food group that takes a hit in the name of potassium, but it is only the condensed and the processed dairy which has to be restricted, again for both potassium and phosphorus reasons. It's not the milk, the yogurt, or the curd that actually has to be restricted. Do include milk and curds in moderate amounts, in the required amounts for each patient, for them to get the other nutrients that are there in the dairy. Now, finally, how do we manage the whole of the potassium scenario? Read the lab reports, observe the trend of serum potassium values over a period of time whenever it's available. Take a diet recall, and a potassium restricted diet is typically around 2000 to 2500 milligrams per day, and it is difficult. So you have to basically put in all the food groups, but include only the low potassium foods in every food group, and consider leaching only when it is absolutely necessary. Now, let us look at the phosphorus regulations that we have for our CKD patients. In adults with CKD 3 to 5, we recommend adjusting dietary phosphorus intake to maintain serum phosphate levels in the normal range. This is what the KDOQI guidelines say, just like how it's said for potassium. So only thing that it suggests is that look at the sources of phosphorus that you are including, because we have the phosphorus absorption from various food groups, whether it is animal origin, vegetable origin, or additives, that is the inorganic phosphates. Based on which food it is, the absorption level change. Now, I don't have to really explain this slide for our audience here today. but especially when we are dealing with children, phosphorus does become a very important because of the mineral bone disease that very often we come across in children and also in adults sometimes. So now, when you look at non-dialysis CKD patients, phosphorus intake is limited already because they are not on a very high protein diet. So phosphorus is always associated or comes more in protein foods, protein-rich foods. Since we are not giving excess proteins to our non-dialysis CKD patients, phosphorus as such doesn't pose a big problem in while planning their diets. But the main thing that we have to look into is the undesirable sources. For example, if it is a young crowd, for that matter, even now in even the adult crowd, if you look, the intake of processed food is highly prevalent. So that is what has to be restricted and avoided completely. It's a strict no-no. For processed food is a strict no-no because it contains inorganic phosphates which are absorbed greatly. Up to 95% of phosphorus from the inorganic phosphates is absorbed. That would be a problem. Now, as I was just saying, if you look at the phosphorus value of each plant source, like a lentil, it would still be high. Same as an animal source, but the absorption is just up to 50% because of the phytates and the fiber. Now, animal sources, the absorption is slightly higher, 60 to 75%, but still that still could be included with portion control. It's the inorganic phosphates which are absorbed greatly, and those have to be excluded completely. And if your patients are not still convinced, give them this list of all the various hidden phosphates in their processed food that can be absorbed and cause mineral bone disease. Moving forward, it's actually again the meat, poultry, fish, nuts, beans, and dairy products which we have to look into when there is seriously a phosphorus issue, hyperphosphatemia. And most often when we are talking about non-dialysis patients, these sources are not included in large quantities because there is a cap on the protein allowance, and thus all these products can be included in small portions. It's the chocolates, the processed milk products, the beer, colas, which have to be completely avoided. And for our pediatric population, we generally give the parents a list of all these foods that have to be avoided, and each food group has a few foods that are really high in phosphorus, like the brown rice, red rice, in the grains. And most often when they are soaked and cooked in a pressure cooker, even the meat for that matter, when they are cut into small portions and cooked in pressure cooker, the amount of phosphorus in the end product reduces to a great extent. Most often the vegetables, fruits, and egg whites are very safe sources when it comes to phosphorus, regulating their phosphorus intakes. Black coffee, when it is filter coffee, it is again a low source of phosphorus. However, if instant coffees are used, again it could add up a lot of phosphorus. So on the whole, if you have to manage phosphorus, you can ask your patient to sieve the whole grain flour to remove the bran, but not use refined flours. Then avoid processed dairy, but do include milk and curd. Cook the slices of meat in soft water in a pressure cooker. Limit the portion sizes as we always do in this group. And then egg whites can serve as a good source of protein and a low phosphorus. Phosphorus to protein ratio in an egg white is quite low. Now, when you talk about acid load, we have been talking about including vegetables, and if you look at a moderate diet of a patient who walks into your OPD, if you take a recall, you will be surprised actually to see that they are not consuming enough vegetables. It's not because they are worried about potassium or they have been told to avoid vegetables. In general, you look at the common population, the vegetable intake is pretty poor. Though we in India are predominantly a vegetarian-based population, it is more of a carbohydrate and a fat intake dominant population rather than a vegetable eating population. So you will have to consciously increase the vegetable intake, include more of the low potassium vegetables to include the fiber and bring down the net acid production in the patient. Also, you could include unsalted popcorn, cucumbers as a snack, and introduce a small amount of fenugreek seeds or fenugreek leaves. Basically, methi is one of the green leafy vegetables that is on the lower side of the potassium spectrum in amongst the green leafy vegetables. This also can be included in small amounts if potassium is not a big problem. And do ask them to include whole grain flours and not refined flours. Only thing is maybe it has to be sieved once or twice to remove the excess brown. Now, moving on to fluid restriction, I don't have to talk much about fluid restriction. We all know that it will definitely be based on the urine output, the stage of CKD, the edema that the patient comes with, if there is a sudden weight gain or breathlessness or blood pressure. And we know as nutritionists that everything that is liquid under room temperature, including ice creams, ice candies, though these may not be allowed to a great extent, these are also counted as liquids. And so make sure that you give this instruction to your patient and make sure that they go back with this understanding that if they have a fluid restriction, they have to count every liquid that is a liquid at room temperature in their chart. So another question that frequently we are bombarded with is that our hemoglobin is low, and what can we do from the diet point of view to improve our hemoglobin levels? Now, we already know that diseased kidneys make insufficient erythropoietin, and this is one of the major reasons for the anemia in CKD. Whereas it takes a while for the patient to understand this. So we have to be patient in explaining, because if you don't explain, then there is the risk that they go home and try all the iron-rich foods that they are advised by their well-wishers, and they may come back with a very high potassium. Unfortunately, most of the common sources of iron, B12 or folic acid are also potassium rich, like the green leafy vegetables, dry fruits, dairy, nuts and seeds. They would be included in the diet to a small extent if they are not having hyperkalemia, but in case they want very overzealously try to include large portions of it. For example, we had patients who would drink beetroot juice every day to improve their HB levels, or we will have patients who will want to take raisins and dates to improve their HB levels. So these are the ones that you cannot let go. Before they leave your OPD, make sure that they have a clear understanding of how much of what they can take, and why diet cannot be the foremost treatment for their HB, and they'll have to most often depend upon their nephrologist's iron prescription for improving their HB levels. So with this, now let us move on to what if the patient is not eating well at all, orally not taking at all, and then they need nutritional support in terms of supplements. Let us see what the guidelines say. Now, in case of oral nutrition supplements, mostly in this population that we are talking about, give an oral nutrition supplement for at least a minimum period of 3 months for them to experience the benefit of this supplement, making sure that it does not increase their electrolytes. And make sure that you explain to your patient that this is not something like a proprietary health drink which is available over the counter, and this is a specific renal oral nutrition supplement which is meant for that particular disease condition. And only it would take a minimum of 3 months to improve their nutritional status, and follow up with this nutritional supplement, whether they require it or you can stop it, and as they have started eating well, that has to be taken care of in the follow-up session. Now, for the other group of patients who need enteral tube feeding or parenteral feeding, these are mostly our critical care patients, or those who are in a bout of serious sickness like infection, superimposed infections and things like that. Definitely, the guidelines recommend using enteral tube feeding or parenteral nutrition wherever required. This is a different ball game altogether, not for today's topic. Now, in adults, when you talk about micronutrients, in adults who are not on dialysis, the guidelines say that encourage eating a diet that meets the RDA for all the vitamins and minerals and not jump into supplementations. But however, in case of very poor nutrition, very poor intake, then the nephrologist's prescription for a water-soluble vitamin and other vitamin and mineral requirements have to be followed. Now, again, the patient has to have a clear understanding that over-the-counter mineral and nutrition and vitamin supplements are not okay for them. So on the whole, when you are talking about diet prescription and patient care for your non-dialysis CKD patient, irrespective of the educational background, a patient needs a detailed counseling on nutritional requirement, a detailed nutrition diet chart with plenty of options for every meal, and then a constant follow-up for a patient who can be monitored regularly. And when we can catch the nutritional mismanagement at the earliest, that works best. Now, also, you have to be really very clear about the myths that exist in the society, because these days with the social media and with the technology at everybody's hands reach, you get a lot of queries, and sometimes without queries, they try to try these things on their own, and they resort to alternative ways of trying to reduce their creatinine and resort to drinking the kashayas and the kadas and other treatments that are often floated around in the social medias. So you have to mention that these come with risks, and then they can always come back to their healthcare team, renal team, and find out if anything like this is suitable or safe for them. So talking to the caregivers, the attenders, regarding the progressive nature of the disease and making it clear that one diet prescription at the start or at early stages of CKD may not hold good till the ESRD is something that you have to be very specific about, and small changes on follow-up can actually go a big way in maintaining their nutritional status and making sure that they enter the dialysis with a proper nutritional status and not with severe protein energy wasting. So with this, I end. Thank you very much.
Thank you. Thank you, Mrs. Sunita Rao, for that comprehensive coverage of the diet strategies in CKD patients. Prescribing the right diet in CKD is always a challenging one, and our eminent speaker had dealt all the aspects of CKD diet so beautifully. And thank you so much for that highly informative talk. So moving on to our next session, the last topic, that is on role of medical nutrition therapy in CKD progression. For introducing our distinguished speaker, I request Dr. Anupama ma'am to take over the session. Over to Anupama ma'am for
Thank you so much. It's an honor to be amongst you, august audience. And if you talk about the risk factors to the progression of CKD, besides the conventional factors, we know that diet plays an important role in progression. And who could do justice to this role of medical nutrition therapy in CKD progression but our own Professor Priyamvada. She is the professor at the Jipmer Medical Institute in the Department of Nephrology. She is a distinguished academician who has nearly about 60-odd publications, both in international and national journals. And the best part of it is she's an ardent researcher, has a lot of international research projects, as well as the extramural projects for her name. Over to you, Priyamvada, for an excellent overview on this topic.
Yeah, thank you, ma'am. Vipul, can you project the results of the poll which we did initially? So, Vipul, are you there?
Yeah.
Can we have the results of the poll? So looks like there is some problem. Am I audible?
Yes, ma'am, you are audible.
Yeah, can you show me the results of the poll?
Results of the poll.
Yeah.
Okay. Hold on.
So basically, when we started off this session, so like a case scenario was given, a 55-year-old man who is not a diabetic. Basically, his weight is 49 kg, and we were given actually 3 options, how much protein, actually 4 options, how much protein we'll give. People just show me the results once again.
Ma'am, actually these results needs to be downloaded from the back end. From the
yeah, can you just read out the results then for me?
Yeah, I'll read out. Hold on.
Yeah. Yeah. Option A was 0.6 gram per kilogram body weight of protein. Okay.
Yes.
Well, and
yes.
Option B was
0.8 milligram.
Okay. And option C?
0.3 milligram plus keto analog 10 tablets.
Okay. And none of the above was the last option.
Yes,
so
yes.
Can you just tell me what proportion of people have opted for A, B, and C?
They have opted for, ma'am, 0.8. 68% of people have opted for
68% opted for 0.8, and the remaining proportion, like next second is
0.6 is 9%, and 0.3 plus keto analog 10 tablets is 9%. Okay. And few people have adopted none of the above, that is 14%. So most of it was 0.8.
Yeah. Okay. So now let's go to the talk. I'm not able to advance my, okay. So basically now we were listening to Sunita and basically CKD diet involves restricting everything, okay. So how much protein, we all agree that this protein has to be restricted. Now, the rationale of protein restriction, basically it goes hand in hand with the sodium. Low protein diet basically leads to afferent arteriolar constriction and an efferent arteriolar dilatation. And it has got some protective effects on the tubulointerstitium and the mesangium. So the other advantages are, Sunita has already told, there will be less amount of ammonia because protein is less, ammonia is going to be less. And many of the uremic substrates like cresols and indole derivatives, they are all going to be less, and we are going to limit phosphorus. Now the question is, how low we are going to limit? Let us have a look at the recent KDIGO and the KDOKI guidelines. And if you see, there is actually quite a lot of difference in the way they are recommending protein. KDIGO has recommended protein restriction to a weight of 0.8 gram per kilogram per day, when the GFR is only less than 30 ml, which means that many of the early stages of CKD, you do not restrict protein. Whereas KDOKI is actually very conservative, and the previous recommendation of KDOKI was 0.6 gram per kilogram body weight per day, and that too less than 25 ml per minute. And now actually they have gone really strict, and they are asking to restrict protein to 0.055 to 0.6 gram per kilogram body weight per day when the GFR is less than 60 ml. Okay, now actually what has changed in the last 20 decades? Is it based on any new trials or any evidence? Basically, these are the trials, not every trial, but the major trials that are actually quoted in the KDOKI guideline as a recommendation for reducing the protein. Now, if you see only one of the trial with very less number of patients, around 228 patients, were actually they used creatinine clearance. And if you see, that's a pretty old study. This is the only study that actually has shown that there is a benefit when it comes to ESRD outcomes. And the third one is actually, I'm talking about the MDRD study, because one problem is when you restrict protein, your muscle mass also might come down and your creatinine also might come down. And this probably might actually spuriously elevate your estimated GFR. So to circumvent this issue, MDRD was one of the very well-planned studies on protein restriction. And what they did was they did the GFR by iothalate clearance, and they did not actually show that, they did not demonstrate that there is any difference in the low protein versus the so-called normal protein. So there are other studies also which did not actually show any difference. Now, in a pooled analysis, the KDOKI has given, there are two aspects when we restrict protein. One is actually preventing death and preventing the onset of end-stage kidney disease. Because less uremic substrate, probably the symptoms will be less and you can push off the dialysis for maybe a couple of months or so. And probably it might actually give a survival benefit also. The second aspect is preventing the decline in glomerular filtration rate. Now, when we read the evidence, we have to see this digit and the alphabet, which comes along with the guideline. And 2 basically means a weak recommendation, and C means the quality of evidence is low. So I believe that the KDOQI is probably a little bit strict in recommending the protein, and that probably is not really backed by good quality evidence. And KDOQI again says that restricting the protein probably is going to be associated with a reduced risk of death and end-stage kidney disease, whereas it does not protect against GFR decline. Okay. The problem is, this is all based on studies which were done from 1989 onwards, where 140/90 bar was actually the normal blood pressure targets, or 140/90 was considered as accurate. And many of these trials, if you see, the coverage of renin-angiotensin aldosterone axis blockers, that was actually like patchy. It was not nearly complete. So basically what we don't know is all these trials which were actually published at least 10 to 15 years early, or even 20 years early, whether this has any application in our current era, where we have renoprotective medicines like RAS blockade, we have mineralocorticoid blockers, and we have SGLT2 blockers. So basically these are all drugs that are capable of reducing the renal fibrosis and the renal hyperfiltration. Now, what is the role of a restricted protein diet in the era of these new medications? Probably we need more good quality evidence. Now, again, basically, this is another systematic review that has actually looked into the same question. Does reducing the protein protect the kidney? Does reducing the protein prevent ESRD? So again, they have all come to somewhat similar conclusion. So basically, if you see the forest plot, okay, it looks like actually probably it's protective, but you just look at the confidence intervals. So possibly the effect on GFR is still controversial, and you can see that actually it protects against ESRD. The confidence intervals are actually very well coming to less than 1. So this is again a Cochrane meta-analysis. Again, eventually the same results. So death and ESKD separately, probably there is not much of a difference in non-diabetic CKD patients. And when it comes to ESKD, in normal protein versus low protein diet, probably there is a protective effect, and it does not actually protect against eGFR decline. So what we know from all this ongoing randomized control trial is probably restricting the protein might delay the onset of end-stage kidney disease. But we really do not have good quality evidence to tell that restricting the protein probably is going to protect your GFR. This is a misconception which probably every single nephrology resident has. They believe that probably restricting protein is going to protect the kidney. But what aspect is being protected? Let us say somebody who is actually having a GFR of 60 ml. The chances that that patient might go to end-stage kidney disease is probably somewhere around 6 to 8% or maybe 10%. Definitely it's going to be less than 10%. And how much time that patient is going to take, it might vary. Sometimes actually they may reach ESRD within a few years, but on the other side, it might take 10 or 15 years. And dietary restricting protein for the 10 to 15 years, is it worth the effort? That is something which we need to think. Okay. Now, coming to protein restriction in diabetes mellitus. So this is what actually like KDOQI says, even though KDOQI says that actually you have to restrict to less than 0.6 in patients with eGFR more than 60. They are a little bit lenient on diabetic individuals. This is basically in diabetic individuals, it will be very difficult to attain glycemic controls if you go very strict with protein, because the calories probably you want to take off the burden of the calories from the carbohydrates. So that is why generally all dietary recommendations in diabetic individual calls for a little bit of higher protein compared to non-diabetic individuals. Okay. So basically this is again actually the list of meta-analysis published so far. And the only thing is the gist of this table is basically there is not much of a reduction in GFR in many of this meta-analysis. So this is basically low protein diet versus usual or unrestricted diet in diabetic individual where the evidence is even weak. Now that brings to another question, whether actually we can have unrestricted access to protein in patients with diabetic CKD and without diabetic CKD. So I'll come to that answer a little bit later in the talk. And now in a community, there are observational studies which actually tells that when the dietary protein increases from 0.8 to more than 1.2, there is an increased risk of GFR decline. But again, what we need to keep in mind is these are observational data, and probably there might be a lot of bias which actually we might not even know. So these are two large population based studies which has recently published, and which has shown that in populations who are at risk of CKD. Basically, this is not done in CKD patients. This is done in patients with myocardial infarction. So the best results are obtained when actually the protein intake is less than 0.8 gram per kilogram body weight. Similarly, this is another study, and the moment actually the protein requirements, the protein intake becomes more than 1.1 milligram per kilogram body weight, there is an increased risk in the GFR decline. Okay. And now, the another way of actually restricting the protein in patients with CKD is actually adding keto analogs. So what you do is you restrict the protein to less than 0.3 milligram per kilogram body weight. So which actually means most of the time you will have to go to a vegetarian diet, and the remaining 0.3 or 0.35 you supplement with keto analogs. So keto analogs are basically salts of this ketogenic amino acids. Instead of one amino group, they will have a carboxy group. So advantage is that they can actually directly enter into intermediates of the citric acid cycle without actually generating from one amino group. So basically, this keto analogs basically reduce the amount of ammonia your kidney has to deal with. So basically that means less amount of urea, less amount of cresols, and less amount of indoles, less amount of acidosis as well. So keto analogs generally will ameliorate the acidosis, and it generally tends to reduce the uremic symptoms. So when we go for such very strict diet, we will have to supplement the other essential amino acids along with the ketogenic amino acids. And this is a recently published very well-designed trial that actually has shown that when people are given a keto analog diet, there is actually like a reduction in the initiation of RRT as well as decline in GFR. And there are multiple studies which actually says similar results. And also there has been studies which has shown that keto analogs are associated with reduced amounts of acidosis, and you can actually go low on the alkali supplementation. But again, what is the optimal dose of keto analogs? We don't know. Generally, most of the major studies has taken as 0.3 milligram per kilogram body weight of protein plus a single tablet for every 5 kg, which roughly corresponds to the remaining 0.3 milligram per kilogram body weight of your kilogram protein of your dietary requirements. Okay, and again, this is basically the all-cause mortality. Keto analog users tend to have better survival in long term compared to non-keto analog users. Now, the problem with the keto analog is, now the question is keto analog an option for everyone? The answer is no. You have to start keto analogs only in patients who are metabolically stable, who are actually amenable to nutritional counseling, and you need intense monitoring so that the patient does not go in for malnutrition. And mind you, malnutrition kills rather than actually a high protein intake. So at any cost, you have to avoid malnutrition. Now, the second thing is this practice of actually not restricting the dietary protein and supplementing 1 or 2 keto analogs. Probably that is a practice that has to be abandoned. It just actually makes a hole in the patient's purse, and probably it is not going to protect the kidneys. Now, there has been multiple studies that has actually used a lesser amount of keto analogs. But basically, the idea is you should not actually increase the total protein intake, whether it is from your diet or whether it is actually a combination of keto analogs, above a certain limit. But unfortunately, the problem is what we don't know what is that safe limit. Whether it is 0.6, we don't know. 0.8, okay, as per KDIGO is fine. And maybe in the Indian setting, where actually we go for a little bit lower quality proteins, probably we can go. We need not be really rigid with the 0.6 or 0.8, because as it applies to Western population, it might not apply to Indian setup. And this is actually data showing what people with, this is US RDS data, and this is what people with CKD eat. Now, you can actually see that the average protein intake is 1.36 and 1.25. That is way above the average intake we come across in Indian population. And all ethnicities, the protein intake is actually much more higher. So we should not actually extrapolate this data to our population. If we see how actually our Indian patients eat, that is actually way below this standards. Now, how much protein you need? This is actually in the absence of kidney disease. So basically, whatever protein we need is there will be daily protein losses in the urine in the form of nitrogen. Then there will be some fecal losses and there will be some integumentary losses. And this is based on Indian data. The total loss in a day for an average Indian is around 68 milligram per kilogram per day. That roughly corresponds to 0.4 gram of protein. So this is the amount of protein that we need to avoid malnutrition, but there is a small catch. This protein is not given intravenously, this protein is given orally, and some sort of wastage will happen. So we assume that around 50% of the protein we eat in a day is wasted. So we add another correction factor of 50%, so that comes to 0.63. So provided we are eating high biological value protein, that 0.6 gram per kilogram body weight is sufficient to prevent malnutrition. But the catch is it should be biologically active. But the problem with the Indian diet is basically the biological activity of the protein is not going to be anywhere closer to 90 to 100%, which means that if we eat protein, only around 50% or 60% might be utilized, and we have to correct for the coefficient of variation also. And that is, after all these corrections, it comes to around 0.97. So basically, the ICMR recommends 0.8 to 0.97 gram per kilogram body weight as the minimum recommended daily allowance. So what is the maximum? It is not given, but this is the amount that an average Indian has to eat to prevent malnutrition. Now, we cannot actually compare our protein intake with people from the Western countries where on an average, they eat 1.3 milligram per kilogram body weight. And at least if we look at the observational studies, and none of the randomized controlled trials have actually put patients on such unrestricted proteins, it would be usually 0.8 to 0.1 or maximum 1.2. So obviously eating a protein of 1.3 kilogram body weight probably might not be in the best interest of the kidney. So on the other hand, eating a protein of a low biological value, probably we need not be rigid with that 0.6. So we have to make allowances to the fact that the type of protein we eat is basically of low quality. This again actually is data from National Nutrition Monitoring Board. And if we see, looking at these figures, body weight of 54, people eat 55 milligram of protein. So there is something called a protein digestibility score, and that score should be closer to 100%. Now, if we look at the score, that's not anywhere even close to 50, which actually means that we end up wasting a higher proportion of the protein that we eat. So while prescribing protein, this actually has to be taken into mind, because Indians generally derive the protein from milk, then carbohydrates, then pulses, okay? And non-vegetarian probably is actually once in a while for many households. So this is actually data showing what Indian CKD patients eat, which includes actually like some ESRD patients. And what we can see is basically most of these studies, the total amount of protein taken by Indian patients are going to be very low. And there is another interesting study. This study basically, it looks like actually all the CKD patients are getting sufficient amount of protein. So but the problem with this patients is basically the biological value. The high biological value proteins basically is very less, and at least 50% of the proteins we eat should be of high biological value. So what I would recommend is, rather than being strict with the amount, you have to find out what actually the patient eats. So a low protein diet may delay ESKD in metabolically stable non-diabetic individuals, but we really do not know whether it's going to preserve the GFR. And another thing is the quality of the protein, because animal proteins generally tend to have more metabolic acidosis. They tend to have more sulfur and other amines, which are actually some intermediates which can cause the kidney to fail in a faster rate, and they can actually affect the creatinine measurements. And there are situations in which you should not prescribe a low protein diet or a very low protein diet. Low protein diet is something with a protein of 0.6 milligram per kilogram body weight, and BLPD is basically 0.3. It could be like a little bit this side or that side, but BLPD should always be supplemented with keto analogs and essential amino acids supplementation. And you should not prescribe a low protein diet or BLPD, because protein energy wasting kills more than actually the kidney failure. So you should not actually prescribe it in patients with the established protein energy wasting. So weight alone is not going to be a factor here. You'll have to see whether there's any sarcopenia when the patient gets hospitalized, when the patient has compliance issues, and frail patients and those with poor appetite. And eventually, when we prescribe a low protein diet or a very low protein diet, we might be actually significantly reducing the patient's dietary intake, putting them at risk of malnutrition. So always weigh the risk and benefits of low protein diets, and always take into consideration the fact that the proteins we Indians eat is of low biological value. Now, the other thing is generally, like when a patient is diagnosed to have CKD, there will be a blanket ban on vegetables and fruits. At least actually that is what the patient perceives. So every single patient coming to my OPD tells me that I don't eat any fruits and I have reduced my vegetable content. That's actually not a correct thing, because see, why we are restricting fruits and vegetables? That's because of hyperkalemia. The chances of hyperkalemia in early CKD is actually fairly less, unless the patient has diabetes, the patient is on multiple potassium-retaining drugs. Okay. The advantage is sometimes actually you can manage metabolic acidosis with fruits and vegetables alone. There is something called a potential renal acid load. So it just comes as a plus or a minus figure. A plus figure means that there is too much of acid, and a minus figure means that there is a lot of alkali. So now you can actually make the patient eat kidney safe or those fruits and vegetables that are actually having a little bit lesser risk of hyperkalemia. And studies have shown that basically by putting patients on fruits and vegetables in early CKD, you can ameliorate the acidosis. You can actually reduce the bicarbonate supplementation. And this is a study which was done a couple of years back, and it actually shows that supplementing fruits and vegetable diet and giving the patient fruits rich in base precursors. So basically, like they have calculated the potential renal acid load, which was actually 60.5 milliequivalents in all this, around 60 in all these three arms. And in the usual care group and bicarbonate group, the acid load did not change over the period of time. But when actually fruits and vegetables were supplemented, the similar degree of acidosis correction was obtained as with the bicarbonate. And see, instead of the potential renal acid load of 60 milliequivalents, their acid loads came down to 38 milliequivalents. Now, the major question is, okay, whether there will be actually any hyperkalemia, okay? Now, basically, this is a study which actually has shown that there is no risk of hyperkalemia. And obviously, there is some hyperkalemia in the ESRD population. This has actually looked into ESRD also. And in the ESRD population, this hyperkalemia is not really associated with the diet. Now, coming to the vegetarian diet. So basically, advantages of vegetarian diet, Sunita has already told. So basically, in addition to reducing the protein burden, reducing the phosphorus, it is actually associated with the preservation of like it actually prevents the patient's progression to ESRD, and it is also associated with a reduced all-cause mortality and longevity. Now, coming to a little bit tricky area. Now, actually, people have all sorts of dietary fads. People are trying to lose weight. And now, actually, there is a lot of emphasis on low carbohydrate diet. And how does this low carbohydrate diet, whether someone with CKD can go for a low carbohydrate diet? So what is called a low carbohydrate diet? Anytime your carbohydrate content is less than 26% of your calories. Normally, as an adult, we need around 3 to 5 grams of carbohydrate per kilogram body weight. And roughly this corresponds to around 100 to 130 grams of carbohydrate in a day. So the very low carbohydrate basically means that less than 10% of the carbohydrates calories will be contributed by carbohydrate calories will be 10%, less than 10% of your total calories, or this is a very restrictive diet. You practically take very minimal amount of carbohydrates to less than 50 grams per day. There's not much data on the safety of very low carbohydrate diet, because most of the time you will be deriving your calories from fats. The so-called keto diet is actually a very low carbohydrate diet, but there is data accumulating on the safety of low carbohydrate diets in CKD. So basically, low carbohydrate diet reduces obesity. It actually improves the glycemic control. So it should actually improve the incidence of diabetic kidney disease in diabetic individuals, or it could reduce the risk of CKD in non-diabetic individuals. Now, studies have shown that the best diet for diabetic individuals is low carbohydrate diet and a Mediterranean diet. They perform somewhat equally. So this is actually a study, a network meta-analysis, which actually has looked into different diet comparison and eventually has come with the conclusion that low carbohydrate diet and metabolic diet, Mediterranean diets are associated with the control. So, but the problem with the but there is a concern with the low carbohydrate diet because you are reducing the amount of carbohydrates. So obviously you might be depending on proteins as your source of energy. So possibly you might end up eating most of the low carbohydrate diets, you might end up eating protein close to 1.4 gram per kilogram body weight. Now, whether that will cause hyperfiltration, whether that will cause acidosis, and possibly there might be a risk of kidney stones, especially oxalate stones and uric acid stones. Now, this is a randomized control trial. So basically, this is a trial which was done in Israel. 3 types of diets were prescribed for patients. One is actually like a low-fat diet. The second one was a 1,500 kilocalorie diet. And basically, what they restricted was like, this is something closer to the Mediterranean diet. Okay, not exactly the Mediterranean diet, but something like a Mediterranean diet. And the third one was based on Atkins diet, and it was a low carbohydrate diet, and 120 milligram was the 120 grams of carbohydrate was the maximum permitted amount of carbohydrate that constitutes to less than 25% of the caloric intake from carbohydrates. Now, what they have shown is people with a low carbohydrate diet basically had a much higher weight gain. And people with a low carbohydrate diet as well as the modified Mediterranean diet, they had actually greatest weight loss at the end of 4 or 5 years. And now, subsequently, they analyzed how this GFR changes. And basically, all these patients included in the study were obese, and most of them had some degree or other of CKD. And now, what they have actually shown is those who are put on a low carbohydrate diet, they actually had the greatest preservation of glomerular filtration rate. And in fact, in some of them, glomerular filtration rate actually showed improvement. Now, the question is whether it is an effect independent of the diet. Actually, the study is not really powered to answer that question. But what they have observed is the people with the greatest weight loss, they had the greatest improvements in GFR. But at least this is some evidence that low carbohydrate diet probably is going to be a safe strategy in preserving the kidney function in patients with kidney disease. And again, another thing is in the direct trial, in the low carbohydrate group, they did not restrict protein and they did not restrict fat. And they didn't even restrict calories. The only restriction was calories derived from carbohydrates should be a particular proportion. Basically, the carbohydrate content should not exceed less than 120 gram. And this is again another study that actually has looked into the low carbohydrate diet and mortality. Basically, they have assessed the mortality across energy intake from different levels of energy intake from protein, fat, and carbohydrates. Now, you can see that once actually the energy intake from protein exceeds 1 gram, there is an increase in mortality. Now, the energy intake from the carbohydrate exceeds 50%, there is a sharp increase in the mortality, and the least mortality is somewhere when the energy from carbohydrate intake is somewhere closer to 30 to 35%. So so at least actually from the existing literature, it looks like low carbohydrate diet probably might be a safe option, but we really don't know whether actually the keto diets where we reduce carbohydrates to a ridiculously low amount, whether that is going to be beneficial to the kidney in the long run. That is actually a gray area. Now, we have SGLT2 blockers also. Now, if you want to put a patient with a diabetes or a non-diabetic patient on a low carbohydrate diet, how are you going to go about? So if the patient is having diabetes, you have to rule out a latent onset autoimmune diabetes. Then if there's no latent onset autoimmune diabetes, start off the low carbohydrate diet, reduce the insulin, rationalize the diuretics and antihypertensive. And once everything is in control, you can actually add SGLT2 inhibitors. Similarly, if the patient does not have a diabetes, optimize the diet. First go for a low carbohydrate diet and then go for SGLT2 inhibitors. Now, coming to the concluding slide. So basically, lowering the dietary protein intake should be an individualized decision. We have to take in due consideration of the local dietary habits of the patients. And BLPD and keto analogs is not for everyone. It can be done in carefully selected subgroups who are compliant, who are ready to go vegan, and who are actually ready to come for frequent monitoring. At whatever expense, the protein energy wasting should be avoided, because it is more likely to kill the patient rather than because of the CKD progression. And plant-based diet have encouraging results recently, and probably low carbohydrate might be beneficial, but we need to have a little more evidence on that. So that's all for the day.
Thank you, ma'am. Thank you, ma'am, for that brilliant talk. You have comprehensively addressed this topic with irrefutable statistical data, leaving no room for any doubt. Thank you for that fantastic talk. Thank you so much. So now I think, ma'am, you can stop sharing the screen.
Yeah.
Now the session is open for discussion, and I request all attendees to type their queries in the chat box so we can take it for discussion now. I request the moderators to take over the session and proceed with the discussion. Right now in the chat box,
you will read out the questions, Jyoti Priya.
Yeah, actually, ma'am, we have only few questions in the chat box.
I think there were two when we finished on bioimpedance.
Yeah, ma'am. So it's actually one question by Dr. Manjusha, ma'am, on the bioimpedance assay. Is the equipment sponsored or is it available commercially in cost-effective manner? And should we have reference standards in each institute? And how frequently should we do the assessment? So I think our first speakers could take this question.
Are they available?
Yeah, that's good.
Yeah.
For anyone,
Manjusha, yeah.
Take this question.
Anupama is there. Anupama was co-moderator with me. Anupama.
Yeah, ma'am, I'm there.
Yeah,
I'm there.
So you may take up the question if the is not there. The speaker is not there. We have to address the question. Yeah, moderators.
Basically, on the equipment of bioimpedance assay, ma'am.
Yeah,
we do. There are individual bioimpedance assays are available at different institutes. I don't know about madam's place, but we do have it at our place, and there have been. I mean, we standardize the equipment for assessment of the fluid and the diet, and of course the fat component of the diet and the weight of the patient as such. So my only concern is that, as ma'am was highlighting, that patients with BIA among children, how do you standardize those things in, because the standardization is different for children as well as for adults. So that's the point of worry for me.
Yeah, ma'am, can I answer the question?
Yeah,
so,
sure.
Yeah, basically, you can actually say one thing is you should not confuse with the bioimpedance analysis and bioimpedance vector analysis. There are actually two slightly different. We derive the data from the same machine, but they are not exactly the same. So now, the problem with the bioimpedance spectroscopy is bioimpedance spectroscopes came into market only maybe around a decade back. Okay. So in theory, they are actually much better than the bioimpedance analyzers, because the more frequencies you use, the lesser will be the chance that you might actually commit an error. But probably most of the literature, not most, a major chunk of the literature on body composition analysis and overhydration in CKD patients and dialysis patients comes with the use of bioimpedance analyzers, which uses only 4 frequencies. Whereas on the other side, the bioimpedance spectroscope actually uses 50 frequencies or plus sometimes. Okay, more sophisticated equipments are coming. The only thing is it's just a matter of time, because if we see, DEXA was not the gold standard till 10 years back. And now actually many of these equipments are validated against DEXA because evidence has accumulated that DEXA is going to be useful. So what I would suggest is, if you are planning to purchase one, you get a bioimpedance spectroscope rather than a bioimpedance analyzer, because bioimpedance, it is basically like having a photocopier and probably a scanner. Okay. So, sorry, a typewriter and a computer. So bioimpedance analyzers are actually tools of yesterday. And tomorrow it is going to be bioimpedance spectroscope. So bioimpedance spectroscopes are available. The Fresenius body composition analyzer, which we are having in most of the dialysis units, that is actually a bioimpedance spectroscope. But the problem with that is, basically the problem is not with the machine, the problem is with the ellipsis. That ellipsis basically is actually validated in a different population who has a different proportion of fat and lean body mass compared to us. So whether that applies in our population, I really don't know. What I would suggest is basically derive the data at 50 Hertz, the resistance and reactance data at 50 Hertz, have your own plots, do it in a normal population, find out where your ellipses stand. Rather than applying the data in a bioimpedance spectroscope, the Fresenius machine data using as such, we should be able to have our own normative data in normal populations. And then we should actually try to plot our graph that will tell you where exactly our patients are. Now, there is a major problem with the bioimpedance spectroscope. Many of the clinicians use it only for assessment of the overhydration. Now, what is the gold standard for assessment of overhydration in Fresenius body composition analyzer? For everything else, like for lean body mass and for other things, it is all actually DEXA, potassium dilution, and all sophisticated methods. But for overhydration, it is clinical assessment. And we know that how wrong we can go in the clinical assessment of overhydration of patients. So bioimpedance, all the information is there in your Fresenius body composition analyzer, but we end up actually looking at the most erroneous part of that analyzer in output.
So, Priyambada, can you hear me?
Yeah, I can hear you, ma'am.
Yeah. So, what the question was that how frequently probably we go for BCM analysis. So, if Manjusha put that question, na?
Yeah. If you are basically, it depends on depends what purpose we are doing. Okay.
What purpose we are doing.
Yeah.
If we are looking at only overhydration, then once the patient starts gaining true weight with good dialysis, good nutrition, then the previous dry weight that we had set would go wrong. So naturally, whenever it is your clinical derivation, it is the patient's input that once you reach the previous dry weight, you are feeling cramps, you are feeling not comfortable, then you suspect that the patient might have truly gained weight because the dialysis could have helped in truly gaining weight. And once the PEW definition comes in, the other nutrition evaluating parameters of a bioimpedance spectroscope, which is BIS, as we all have in our dialysis units, and we do not assess nutrition, rather assess only hydration with that machine. So to address Manjusha's question, I would go rather in a way that it would be the clinical input and the patient's input, that when you should go for a reassessment of BCM and probably clinically adjust to some extent, then again reassess for the weight by BCM. But for nutritional assessment, which we hardly clinicians do with spectroscope, isn't it true, Priyambada? We hardly do nutritional assessment.
See, basically, we can actually do, this is actually a tool which has actually, because the advantage is you can use it bedside. You don't need any complicated assessment or anything. So madam was telling about this question of dry weight actually going up during dialysis. That is exactly what the bioimpedance vector analysis is going to help you. You will actually see that the vector is more going towards the normal body weight status from the overhydration. So it has actually a lot of applications, at least as maybe like a bedside tool. Actually, it has a lot of applications, and we often do not
underuse it.
I have used this Fresenius body composition analyzer. I personally do not believe the hydration status it gives. And most of the time in people with slightly lower weights and females, it actually gives a lot of erroneous reports. Probably the reason why it is not. The ellipse is actually not standardized for our population.
Maybe. And probably with the definition of analysis becomes important, because in that definition, you may find the anthropometry and the bioimpedance based calculations are there to satisfy the PEW definition. There are clinical part, there are anthropometric part, the biochemistry part, and the bioimpedance based assessment. So we may move to next talk's question, Jyoti Priya.
There is another question that's posted by Amit sir. It's on are the dietary calculations based on ideal body weight? That's the question posed by him.
Sunita ma'am. The protein prescription is per kg ideal body weight or dry body weight?
Yeah. So basically, earlier we used to, for dialysis patients, we would definitely use the dry body weight. Even now we do that. We use the dry body weight for protein prescriptions and for even other calorie prescriptions as well. But when the patient is not on dialysis, now as I had just mentioned in my talk, the guidelines don't really stipulate using either ideal, dry, current or actual body weights. They say go by the case basis. For example, as I had just mentioned, one of the case studies where the patient was extremely protein energy wasted, there we really did not stick to his ideal weight. We just calculated for his current weight because he was undernourished. So based on the patient condition, we can actually use the ideal weight or the current weight to calculate their protein requirement.
In our setting, we usually use per kg present body weight, that is dry body weight, after getting the dry body weight calculations, pre-dialysis. But if the patient is on dialysis, we don't mind providing as high as ideal body weight. So even for the calories, we usually choose on ideal body weight because we do not want sarcopenia, we do not want protein energy wasting. So we calculate calories for ideal body weight, whether it's pre-dialysis or post-dialysis. Or I mean to say once the patient is initiated on dialysis. But pre-dialysis, we usually go with present body weight in terms of dry body. That's the usual way we do in our setting. And also, I wanted to share one little thing was, in January 2023, there is a recent publication with reference to potassium and protein, the percentage which is lost on leaching. It says that potassium reduction in beef and green leafy vegetables is as high as 40 to 49%. In chicken and fish and non-leafy vegetables, it is 30 to 39%, and in tubers, 10 to 20%. This is with reference to potassium. And with phosphorus, when you do the leaching with reference to beans, it is as high as 30 to 39%, and non-leafy vegetables 20 to 29%, and beef, chicken, and fish 10 to 20%. So we have some paper, thankfully. I think recently in the last 2 to 3 years, we have few papers to tell us the percentage of potassium and phosphorus which is reduced on leaching.
Absolutely. Now, actually, the process of leaching, the time of leaching also would,
yes,
we would have to really mention all those things.
Yeah, this particular paper says that if you use 1:5 ratio, meaning if you've used vegetable 100 grams, you need to use at least 5 times the water.
Absolutely.
And you need to soak it in hot water for 5 to 10 minutes and then give it a boil and then discard the water. So there are several methods of leaching. Each one talks differently. If we have some Indian data to tell us, that will be great.
Absolutely. But the only major issue with leaching would be that patients become very non-compliant, or the amount of vegetables they take in would drastically
come down. It all depends on if you can add some seasonings and make it a little more palatable. Most of the patients go home with the idea that we need to leach and not season it. That's another big problem. So when we do the counseling, I think the counseling should add on saying, remember to season, not to just leach it and consume it. Then nobody would consume it that way.
Yes. All those small nitty-gritty details that we do during counseling matters a lot. It is absolutely.
But the best method we've seen is pressure cooking it and discarding the water. Though when we were in CMC Velo, we did learn, you boil, discard, 3 times. That's what we learned from Sarah ma'am 35 years ago. But of late, what we've seen, the best method is pressure cook it and discard the water.
When phosphorus restrictions are absolutely required, we do advise pressure cooking. But most of the time, we try to avoid leaching for potassium purposes by mix matching the vegetables that they can. But there are patients who really require leaching, and then we would go ahead.
Yeah, basically customized.
Yes, customized.
There is
There's
another.
another
Ma'am,
question.
I wanted to make a mention, Priyambada ma'am.
Yeah.
We've seen lot of keto patients. Even today morning, I had a patient who's having ketones 2+. It's really
Yeah,
crazy.
yeah.
The
Yeah,
people
yeah.
are crazy. They
No,
go
they.
diet and they restrict their fluid also. And we see
Yeah.
them with hyperuricemia, as you made a mention. But we see
Stones.
the urea creatinine also raised in normal healthy population.
Yeah.
So I really wonder whether these low carb diets will do great wonders for
No,
us.
none of the low carb diets were actually keto diets. So whatever actually that studies, that is something which I wanted to emphasize. I think actually I had mentioned those low carb diets, they are actually not
130 grams carbohydrate.
They are
That's not
actually
low
around
at all.
100 gram of
that's not low at all.
carbohydrate is there, and the protein probably might be, see, even though many of those studies actually does not mention how much protein is there,
they consume as
probably
high as 130, 150 grams.
No, protein intake probably might come from 10 to 15% of the calories to it might be 20, not more than that.
Yes.
So that is actually still within permissible limits, and probably if we actually ask people to restrict carbohydrate, and even if they're given the choice to ask protein rich food, I don't really think nobody will be crazy enough to eat that much of fat which keto diet followers recommend.
That's very unfortunate.
That perhaps is unhealthy, and I have had patients with uric acid stones and even oxalate stones also. We don't really know, because it is actually creating a lot of oxidative stress in the body, and how it is going to affect. Short-term studies shows that keto
Padmavati Institute in Tirupati, wherein they found that there was damage to the liver and the kidney in less than 12 weeks.
Yeah.
Which
so
is not observed in the form of renal parameters, though at that moment.
Yeah, so that was what I told. There is no data on the safety of the very low carbohydrate diet, because a very low carbohydrate diet, you don't have a choice other than to hike up your protein and hike up your ketones. So what I told is low carbohydrate diet.
Yeah, ma'am.
These patients.
Yeah.
And then
and they were not CKD. I don't think they were CKD. They were only obese.
They had CKD. They had
they had CKD also.
In the direct trial, all of them had some degree of CKD because they were diabetic and obese. So obviously, they will have some degree of kidney damage. And the thing is actually whether there is an effect independent of weight loss, because probably one thing which accelerates the CKD progression in these patients is actually they are overweight. And it is obesity related issues. And once obesity comes down, the glomerular damage also is going to come down. So the whatever renoprotective effect, it correlated well with weight loss. Now, whether it is going to be an independent effect, fine, we don't know. At least what we can tell is in obese individuals, probably we can actually sort of safely go ahead with a low carbohydrate diet without thinking that it's going to damage the kidneys, because we have actually hard evidence from an RCT.
Thank you, ma'am.
Ma'am, there is a question to Priyambada ma'am from Dr. Rajiv Alojana. It's on intermittent fasting and its role in the progression of CKD, or how it affects the CKD.
I see. Basically, eventually, intermittent fasting basically works by restricting the calories and restricting the carbohydrates. So what I would suggest is any palatable diet which actually needs, and intermittent fasting, you don't really put any cap on calories, but only thing is the window in which you are going to eat is actually less. So probably you might not end up taking too much of calories. So if you're asking at data, probably I don't really think any data exists on intermittent fasting and long-term cardiometabolic outcomes. So probably I really do not have an evidence-based answer, but at least what I believe is it is not going to be as bad as the keto diet.
Oh, yes. Sure.
Thank you.
Though there is some data to tell us that intermittent fasting is actually equivalent to calorie restriction. There's no difference, but unfortunately, we've seen a lot of patients, they want to eat a large meal at 4 a.m. in the morning. They want to eat a very, very large meal. So absolutely no calorie restriction. Which way is an time restricted eating going to really help?
And another thing is actually like what at least I feel is people who practice intermittent fasting probably end up restricting proteins, especially with the Indian diet. because like we might not end up, even otherwise actually our protein requirement for a vegetarian is slightly on the lower side, and the worst thing you should actually have is to lose your muscle mass. So if the weight loss happens at the expense of sarcopenia, that again is actually going to complicate everything.
Also, when they do this long hours of fasting, the metabolic acidosis, what would happen to that? What would you comment on that?
Yeah, some mild amount of ketosis probably might develop in certain individuals, and they might actually become tolerant to that.
I think even if they follow intermittent fasting, it has to be the timings of the meals also need to be specified. That would be really important.
Yeah, because these are gray zones. Okay, it is actually like proven that intermittent fasting is associated with weight loss, but how it actually performs in the long term, that is a big question that actually needs to be answered.
And there is a query on the protein sources and the plant-based protein source. Is it the one which we could recommend?
Yeah. Maybe Sunita, can you answer that question?
Yeah, I had actually covered most of the protein sources that we could include in a CKD diet. If you are talking about plant-based protein sources, it's always a cereal pulse combination to complement the, the type of amino acids and give a complete set of essential amino acids. So always use a cereal pulse combination, lentil, or even if it is whole grams with the skin, without the skin. These are the protein sources that would be the sources of priority. Next would be the dairy sources. And then if you're talking about nuts and seeds, then you will just have to check with the if the person needs a phosphorus restriction or over and above how much of protein you would want to give. So the nuts and seeds would be the last priority, but the lentils would be the first priority. Dairy would be the second one. Now, if you can include egg whites, that would really be wonderful. Egg whites, and then portions of lean meat. Based on the case scenario. These are the typical protein sources. We typically avoid red meat for the reasons that we just mentioned about the uremic symptoms, the byproducts of animal protein digestion.
And regarding
also oats is a source of beta glucan, and there is some evidence to tell us that it prevents the progression of CKD. So if potassium and phosphorus is not an issue in early stages of CKD, I think it's a great
it's an excellent source of the soluble fiber, which when we were talking about gut microbiome, the CKD and the gut microbiome connection, oats does come in.
And regarding fishes, is there any restriction for any particular group which we prefer or not prefer?
No, if you look at the Indian food composition tables, basically the phosphorus, potassium, and the protein content of most of the fish are very similar. So we do have these queries, especially from people coming from the coastal regions. But technically, the protein, potassium and phosphorus content is the same. Now, probably the only difference would be in terms of seafood, which are the mollusks, where the calcium content would be a little higher. So otherwise, other fish are all okay.
But there is some concern of dioxins and mercury, which is another of late
that is for
problem.
All the population. All the population.
That's a problem everywhere.
Yes.
Of late. That's a new problem.
So we have patients coming from other countries like Maldives, where fish is the staple. So there they do consume octopus and other reef fish and the fresh and the tuna. So what we have seen is regularly it is the seafood, the octopus and the seafood that land them up in trouble, but the other reef fish and the tuna don't cause problems in long terms.
Any queries or any comments from our other moderators, Dr. Anupama ma'am, Dr. Rajiv Alojana? Any comments?
Just one question to ask Priyambada.
Yeah.
Actually, we are talking about patients who are going on down to the extent to having diabetic kidney disease. So we start with the stage when we have diabetes, which is hyperfiltering kidney. And that stage, when we're talking about SGLT2 inhibitors and other drugs added on, what do you suggest? What would be the role of protein therapy? See, what is happening? What we are trying to consider those obese patients who are diabetics, who have hyperfiltering, and in those patients, you're trying to give keto diets. And because we know that protein per se can cause hyperfiltration and injury to the kidney. So what do you suggest in those group of patients? What should be the dietary application for those patients?
Yeah, ma'am, that question exactly was actually answered by the direct trial. So basically in the direct trial, what they did was they selected obese diabetic individuals, and many of them, a good majority of them had evidence of kidney damage, almost like 90% plus or so. And they actually did not put any restrictions on protein. And what they did was they put someone on a Mediterranean diet, and Mediterranean diet, actually there was some amount, it was not very grossly restricted protein, like it was around 1.2 to 1.3 was still permissible. And in the low carbohydrate diet, they didn't bother to actually restrict the protein at all. So what they found was basically that whatever kidney damage, proteinuria, everything improved with actually better weight gain, better weight control. So what I would suggest is, rather than actually pharmacologically managing and trying to actually restrict the protein just because that it might in theory hyperfilter, I would actually ask the patient to, and I would encourage the patient to lose diet. Suppose if they lose 5 kg weight over a period of 1 or 2 years, that is actually going to benefit them in long term. So at least in the early CKD, probably I would emphasize them on weight gain, but probably I won't do that if they are actually very close to ESRD, because probably at that time the fat probably is going to protect them. But early in the stages of diabetes, I might actually go a little bit relaxed on protein, because that is what exactly the direct trial, it's actually, if you go into the trial, it was published in NEJM in 2008, and the subgroup analysis was published in 2013. And you could actually see, I don't think that actually you can do a dietetic trial in a better way. So this is such a very good trial, which exactly has answered this question. You lose weight, ignore the protein temporarily, lose weight, that is actually going to produce beneficial effects in long term. Okay. In fact, albuminuria also came down.
Okay. I think we are running short of time. Any comments from Dr. Rajiv Alojana? Any suggestions or inputs?
I thank Dr. Priyamvada ma'am for this opportunity and an excellent presentation by all the speakers. The only question I have is to Arpana ma'am. We at our center use the in-body multi-frequency BCM, but what we find is it is also useful in AKI. We use it in many patients with AKI, where we assess the amount of the catabolic state. It's a little difficult to assess the lean body mass, but at least the overhydration, definitely it helps. Is there any experience from your side with this?
Absolutely right, Rajiv Lochana. This tool is used even in acute situations in AKI and ICUs. We have several studies on that in adults and in children with BIS, in children with AKI and who are undergoing CRRT. So I have not personally had to undertake a study in AKI, so I'm focusing on CKD, but you're absolutely right. So overhydration is something which would help. And I think many hospitals, corporate hospitals, at least in Bangalore, are using this in AKI and ICUs.
Okay. I think if there are no more comments or any questions, we can wind up the session. We have come to the end of today's Win India webinar. We had a truly remarkable and an insightful academic talks and brilliant discussion. Thank you once again to all the eminent speakers and the moderators. Thank you for all attendees for being with us till now. Thank you once again, and looking forward to meeting you all in the next Win India academic webinar. Thank you. Have a good night.
Thank you, sir, Dr. Amit sir, for joining us and staying with us till the end of the session and also interacting with us. And of course, thanks to Priyamvada for driving in the whole session. It's been an excellent session, I can say. I think the questions are just going to be innumerable and something like a Pandora box. So we look forward to have many more sessions. I'm sure Priyamvada will take this forward with many sessions coming up in future. Thank you so much. Thank you, everyone. And thank you, special thanks to Dr. Amit Gupta for joining us despite his busy schedule.
Thank you, Mr. Manjusha. That was great. And I really enjoyed listening to all these fantastic talks, and I've learned a lot. Thank you so much indeed.
Thank you, sir. Thank you. Thank you, everyone. Thank you so much. Thank you, the technical team, Vipul. Thank you so much for joining us. Thank you, everyone. Good night. Good night, everyone.
Thank you, ma'am.
Thank you. Thank you.